Three, two, one. We are live now, sir.
Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Foxy Symbiosis series, webinar 15, on the topic clinical research methodology and reproductive medicine. Before starting the webinar, we would like to have a lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Happy Doctor's Day to all of you. Today's theme of the Doctor's Day is Healing Hands, Caring Hearts. I would like to introduce Dr. Monica Singh. Dr. Monica Singh is Managing Committee Member ISAR. She is also West Zone Coordinator, Medical Disorders Committee, FOXY. She is convener of ISAR Perfection Series and convener of FOXY Symbiosis Series. Over to you, madam.
Thank you so much, Dr. Vishal. And I sincerely extend heartfelt thanks to FOXY Clinical Research Committee, chaired by Dr. Surekha Tayate, and FOXY Infertility Committee, chaired by Dr. B. Kalpana ma'am, under the Vice Presidentship of Dr. Charmila Ayavu, under a dynamic leadership of FOXY's President Dr. Jaideep Tang and Secretary General Dr. Madhuri Patel, because of whose permission and because of whose benevolence we could carry this symbiosis forward. And as we can see, today is the symbiosis between two great topics. Clinical research methodology should be in the background of every study we do. And along with that, good evening, ma'am.
Hello.
Okay, ma'am. Ma'am, I'm sending you the faculty link once again, ma'am. Once again. Yes, yes. Sure, ma'am. Sure, ma'am. Sure, ma'am. Dr. Nandini, please, can you help Madhuri Patel, ma'am, to join? Dr. Nandini, Dr. Purva?
Yes, ma'am. I'll help. I'll do that,
Yes,
ma'am.
you have her number. Please forward her the faculty link to her, madam.
Yes, ma'am.
So continuing the program forward, I must say that infertility is a subject which is subject to daily change. And this is something which has to be very evidence-based, because just now I had two positive IVF pregnancies. Both of them turned out to be missed after about a week or so. So, anything a little goes wrong in your practice and you have, a sort of a pregnancy failure. So it's a positive turned into negative, which gives you a lot of heartbreak, a lot of sorrow to the couple. But at the same time, you have to be patient, gentle, very, very understanding to patient and go on, because you have got clinical research and evidence with you. You have studied the subject. You are doing daily studies and you know what to correct and how much to go ahead in the subject. So I really sincerely thank Dr. Charmila ma'am and Dr. Surekha and Dr. B. Kalpana ma'am for giving us this opportunity. Dr. Vishal, can we please continue the slides? This is the program we have in front of us. As we can see, we have got three great talks. We start with research studies in infertility. What are the best practices in conducting them, which is going to be taken by Dr. Surekha for 30 minutes. Then we have got Dr. B. Kalpana speaking on the significance of DNA fragmentation index in male factor. And then I will be speaking on poor ovarian response. This will be followed by a great panel discussion on practical approach to ovulation induction, where we have got panelists from all over India. We've got moderator Dr. Padmaja and we've got expert Dr. Papa Dasari from JIPMA. We welcome all faculties from all over India, and we sincerely thank our office bearers, Dr. Jaideep Tang sir, Dr. Madhuri Patel ma'am, and Dr. Charmila Ayavu. So I think Nandini, has madam been able to join? You can display the CV of Dr. Madhuri Patel, ma'am, Vishal.
Are you able to see the screen?
Yes.
There is no voice from madam.
Madhuri madam has joined.
Yes, ma'am, sending. Dr. Vishal, we'll have to send madam the user ID and the password to join. There is some problem at her end. Can the technical support team help?
Madam, I make a phone call to them. Just allow me minutes,
Yes.
2 minutes.
Yes.
I call
So,
them.
ma'am, till Madhuri ma'am joins, can we have Charmila ma'am's address?
Yes.
Madam, you can start your ma'am VP address before madam.
Thank you, Monica. It's an honor to be in a program where two committees with us, Clinical Research Committee and the Infertility Committee are doing together. And two great talks by both Sureka and Kalpana, as well as a talk by Monica. And as Monica was talking, it was very clear that so much of dedication goes into the preparation for these webinars. And Monica is doing so much of hard work. And we'd like to invite all the speakers and chairpersons, panel moderators, as well as the panelists for this program. And I'm seeing that you spaced it out quite well. Giving talks for half an hour is unheard of in webinars. Usually in 15 minutes, we are asked to wrap it up. So 3 talks of half an hour each and a panel for 2 hours. That is unheard of. Recently, we did in a conference where in 10 minutes, we were asked to wrap up the panel. We hardly had any time to introduce each other. We finished off and great time spacing as well as wonderful talks, well curated by Monica. And to wish all of you the best, especially to Monica for her elections as well as for a wonderful program by Sureka and Dr. Kalpana. Thank you so much for inviting me. And I'm seeing Dr. Sarveshri there. Thank you so much, ma'am, for joining the program. It's an honor to have you with us. Thank you. I think Madhuri ma'am has joined.
Madhuri ma'am has joined. Can we have?
I finished my address, Monica.
Yes, thank you so much. Thank you so much, Charmila ma'am. If you could just stay for ma'am, Sureka ma'am and Kalpana ma'am, would you like to welcome Dr. Madhuri? Or because
Yeah,
Jaideep sir.
thank you so much. Thank you,
Yes, sir.
Dr. Monica. And at the outset, I would like to thank the Foxy office bearers, Dr. Jaideep Tank and Dr. Madhuri Patel, for offering this opportunity for coalition between the two committees, which is the Clinical Research Committee and Infertility Committee. And of course, Dr. Monica is there, who has done a lot of hard work. I would like to welcome our Secretary General, Dr. Madhuri Patel, ma'am, who we all know as the people's person. And because we see her traveling to not only the bigger societies, but all the nooks and corners of the city, of the country. She has been traveling to be with the Foxians themselves. She's the Secretary General, and she has been working for Foxy since last 12 years. Starting from the lower rungs and coming up every 3 years, going up the rung, and now she's the first female Secretary General of Foxy, and we have seen her and we know her as a very hardworking person. Even if you call her or text her at 2 o'clock in the night, she'll immediately respond. That is the way of her working. Madam, we are really, you are an inspiration to all of us. And for every small bit of work, we can call you anytime. Such a good approachability Madam has. So over to you, ma'am, for your blessings for this webinar.
Yeah. Sureka, can you hear me? Monica and Sureka?
Yes, ma'am. Yes, ma'am.
Yes, yes. So thank you, Sureka, for
We can't see you.
your thing, I don't know why it is giving me trouble. Hello?
We can hear
Yes,
you. We can hear you.
Can you hear me
Yes,
again?
ma'am.
Yes,
Yeah.
ma'am. And your video
Can
is
you
not.
hear me?
Yes.
Can't
Yes.
see you.
Hello?
Just your video, madam, if you can start. Otherwise, we can hear you.
Can you hear me?
Yes, ma'am.
Yes.
You're audible, ma'am. You continue.
Hello?
There is some problem with madam's.
We can't see her.
Yeah, she's there. She is there, but she is not able to
Can you hear me now?
Yes, ma'am.
Yes.
But I can't hear you. I can't hear all of you. If you can hear me, I can just talk from my end.
Yes, ma'am. Yes, we can hear you.
Madam, you are audible. You can continue, ma'am. You are audible. I think give her a call, Monica. I think madam is not able to hear us.
Ma'am, can you join again, ma'am? I think.
I'll call her.
Madam, she is not receiving the call right now. Ma'am, I think we can have.
No, she said she's going to speak.
Okay, okay, okay.
I think hope that she has not joined from the other link. This is the faculty link only, no?
Yes, ma'am, this is the faculty link, which I have forwarded
Madam,
to all.
please go ahead. We can hear you. She said she's going to speak.
Yeah. Otherwise, madam is always there at the beginning of the program. She must be having some technical issues in the program.
Now we cannot see her audio also. So probably there is some big problem. See, the audio sign is also not there.
Yes, yes. Technical support can help her out, Vishal.
No, she has
Madam,
to join again.
she has to
can-
join again actually.
I think madam has to leave and join again. That will be better.
Madam, please leave and join again. That will be better. Yeah. Till that time, sir, we can have blessings from Dr. Sarveshri Nautil, ma'am. Yeah. Sarveshri, ma'am. We can have can we have her CV, please?
Yeah.
So we know her as mentor to everybody of us, I think. She has been such a great person, helping all of us and to network, to connect with people. So founder, director of Kishori Foundation, and she has been the director and of medical health and health services of government of UP. That's a huge honor and such a lot of work. Senior consultant colposcopy at the Regional Cancer Detection Center at Allahabad, Superintendent-in-Chief at the District Women's Hospital, Allahabad, Principal Worker for Project for AIMS New Delhi and Screening Program for Hypothyroidism. And of course, we all know her as our mentor, Madam, and seek our blessings.
Thank you. Thank you so much, Surekha. Such a nice word.
Yes, ma'am. Please go ahead.
Sorry, I don't know what happened.
Ma'am, we can hear you. You need the program, madam? You need the
Maybe
flyer?
I was there. I don't know how can okay, can you hear me?
We can
Yes,
hear.
ma'am. We are audible. You are audible.
Okay, okay.
We can see you
So
also.
I'll give my message. So then I will do it. Okay. So good afternoon, everyone, and thank Foxy Clinical Research Committee Foxy Infertility Committee, and Bhopal Ops and Gynae Society for giving me this opportunity to be here today with such a learned people around. So, Monica, you have arranged a webinar that is Symbiosis. The name suggests it is different kind of webinar in which two different specialty are coming together and giving benefit of knowledge to all the delegate and of course faculty also. So the topic of today is clinical research methodology and reproductive medicine are need of ours. I know all are going to have a real academic piece. I know Sudekha, I know how much knowledge she's got. If anything you need, you can go and ask Surekha. Surekha, can you help in this? And she will take out some way to reach you there where you wanted to go. So thank you so much, Monica, for giving me this opportunity to be here. And I think one thing I want to say that we should see who is working how much, who is working so hard. So we should support the person. We should support the Monica. We should support her for the chairperson in perinatology committee. I think my best wishes and blessings from Uttarakhand I'm taking with me towards you, sending them. Thank you so much. Thank you, Sureka, for the nice word. Thank you, Monica, for giving me this opportunity to join here. Thank you.
Thank you. Thank you so much, ma'am, for blessing from the land of Devbhumi.
Now I got my net back and you can see me here.
Yes. So,
It happened. Okay,
ma'am,
thank you so much.
Thank you. Thank you so much, ma'am. And just before introducing our guest of honor, Dr. Maushmi, ma'am, I would like to speak a few words about Dr. Surekha, ma'am, if she allows me.
That's fine. No, let's first introduce our guest.
Right, ma'am. So, ma'am, I now would like to introduce, ma'am, would you like to introduce Kalpana, ma'am? Would you like to introduce Maushmi, ma'am? Kalpana, ma'am, would you like to introduce Dr. Maushmi?
Yeah.
Yes. Can we have Dr. Maushmi's here?
Good evening, everyone. I'm really happy to welcome you all for this wonderful webinar organized by Foxy Fertility Committee and also Research Committee and its committee chairperson, Dr. Sureka, in association with Symbiosis. Symbiosis by Dr. Monica and Randir Singh, under the leadership of Foxy President Jaideep Tanser, Foxy Secretary General Madhuri Patel ma'am, who is the first Lady Secretary General, humble, hardworking, and the words are really endless. Ma'am, we would like to hear from you your blessings.
Thank you, Dr. Surekha, Kalpana, and Monica. I'm really grateful that I could ultimately join for this webinar, and I'm really happy for the same. So let me wish all of you the happy Doctor's Day. We all are working hard, and as Dr. Jaideep always says, that we are putting so much of hard work, so we should appreciate ourselves, and we should continue to do this. And this is, named after our Dr. B.C. Roy from Kolkata. He has done lots of work in medical field and as a politician also. And his birth date and the death anniversary are on the same day, 1st July, and we celebrate this Doctor's Day. So happy Doctor's Day is once again, which boosts us to do more and more work. So with this, respected our President Dr. Jaideep Tang, Dr. Sharmila, Dr. Surekha, Dr. Kalpana, Dr. Anita Srivastav, Dr. Shabana, Dr. Monica, Dr. Randeep, Program Coordinator Dr. Neetu, Dr. Purva, Dr. Nandini. And I can see is Dr. Amit Patki has joined. He's a chief guest, and our guests of honor are, Dr. Sarveshwari and Dr. Mausami. They are very, very dear friends to me. I have been so many times to Kolkata as well as recently in Dehradun, and they have really taken care of me. And then, of course, we have Dr. Umya, Dr. Niket, Dr. Nivedita, Dr. Reena, Sridevi, Dr. Neelam. She's also another good president of Muzaffarpur. I had experience in the last week. Dr. Kalyani, Dr. Padmaja, Dr. Papa Dashari. Dr. Papa Dashari, I always remember when I go through the journal, our editor-in-chief, her article is always there. So it is very nice to see Dr. Papa Dashari and Dr. Ani, Dr. Uma, and all other panelists and my dear friends. Very good evening to all of you. I am so happy to join in this webinar that it is going to talk on best practices for conducting research studies in infertility, male factor and significance of DFI, evidence-based guidelines on management of poor responder, and of course, panel on the case-based discussion on ovulation induction. So these are so many important things, and Surekha is going to give highlights about the research methodology. As an editor-in-chief, I would like to mention that we have this PICSEP program about the research methodology, and recently we had in Bhopal, and it was such a good crowd we could get, and so many people are interested. We have been started this program since 2004, and now almost 20 years after that, we are getting good papers on the, in the journal. And I must say that journal is, this academic wing of Foxy. We get more than thousands of, original articles and the case report, etc. And we have to select only 110. So it becomes very difficult for us to reject the good papers, but we have to remain in our limit because we keep on producing supplementary, then our impact factor goes down. So we are, what you say, we are with all agency, our indexing is done, except for the Medline, which we are trying for that, and they want even high impact factor. And Mausami will agree that how good the program was, and we really enjoyed, and Bhopal, Monica, and Anita, and Sultana. They all had done, Shabna, they all have done excellent work. So now I would like to take this opportunity to talk two things. One is that we have started a web series on clinical pulse of yogi. It is held on every third Wednesday of the month between 4 to 6 p.m. And it is here we invite our award-winning, journal articles, authors to present themselves. And this has become very, very popular. And I want you to join on third Wednesday of the month between 4 to 6 p.m. We send the link by SMS and email and on the WhatsApp also. So I want all of you to join. And secondly, now the elections are on. We are going to open from 1st July, 1st August, presidents and the vice president election, and then chairperson and the ICOG. So I request all the people who have joined over here, please update your data on the portal called as member.foxy.org. Because at the time of election, I sleep only for 2 hours. Many people call me at 2 p.m. or 2 a.m. also and 6 a.m. also saying that, we have not received the link. So there are 4 problems with the link when you don't receive. One is your subscription has not come before 31st March. Second, you are not A category member. Only voting link goes to A category, and the B category 1, where they are MBBS before 2007, and there is a continuous, membership in the Foxy. They are also given the voting rights because when the amendment of this happened, that time it was 2007. So we never apply any amendment retrospectively. So B category 1, they are also entitled for voting rights. Thirdly, many of the people are, postgraduate in OBGY, but they have not, there is a certificate is not there. So I want them to upload this certificate and become a category member. We are sending on mobile, SMS as well as on email link, but both the mobile and email are wrong. And sometimes the husband and wife, they use the same link, mobile as well as the email. So, one person does not get. So last time what we did, we put one email of the husband and the mobile of the wife. So, that way we could get over some of the situation. So there are many, many things. So I request you to update your data on member.foxy.org. If you cannot do it, please sign to the Foxy office. We will update your data. So it is open only up to 16th of July. So I hear people who are gathered, I want them to see themselves, verify, otherwise change accordingly and update them. So with this, I'm not going to take more time now. Two important things I wanted to pass on to you. And thank you very much. I congratulate the organizer. And Monica is doing, this is a 15th, I think, series of this program. And I congratulate all the organizers, including Kalpana, Surekha, Monica, Jaideep, and Sharmila, for the best, app webinar. And I wish them all the best. At the end, I would like to quote Benjamin Franklin, that investment in the knowledge gives the best interest. So dear friend, let us, invest in the knowledge, update ourselves, and give the best to our women. Thank you once again for giving me this opportunity.
Thank you so
Thank
much.
you, ma'am.
Thank you so much.
Excellent.
Madam.
Thank you so much for the guidance.
Mm.
Can we
And
now?
Madam, yes, ma'am. And Madam's presence is always there, Surekha ma'am. She always makes it a point to come to Symbiosis. Even if it is for 10 minutes, she will come and she will always address us. So
That's
she is like a
Monica, last
she is
time I
like
could
a
not attend Surekha's and some one more person. They were just surprised. I said, no, I was just held up. So excuse me for sometimes it may not be possible, but I try to, log in every time. Thank you once again.
so very much.
We love
last
to
to
see
last
you,
time you joined
Madhuri,
from there.
with the positivity.
Yes, Sarveshwari, thank you very much. Thank you very much.
Can we now introduce Dr. Maushmi?
Yes, ma'am.
Yeah.
Would you like to do this?
Yeah, so I would just like to
Yes.
welcome Dr. Maushmi on the platform. She is a really beautiful, wonderful human being, my dear friend from Kolkata. She is, as you can see, very much accomplished consultant OBGY from Kolkata, president of the Bengal OBGY Society. We are seeing her doing such a huge lot of work, conferences after conferences, and that too, large ones, welcoming people, arranging their travel, accommodation, everything, organizing chairperson of Fitovision, Boxcon, Endogyne, Wisdom, and I think many more to come, vice president of IMA. And again, she was the organizing secretary of Boxcon, FWCon, BIMACon, and of course, she's the organizing chair of the hospitality subcommittees and convener for the AICOG as well, orator of prestigious orations. These are the very beautiful orations. Dr. Mary Katstur Memorial Oration, Shukumari Memorial Oration, Urmila Roy Memorial Oration, and of course, such a humble person, I think, organizing so many things and so welcoming and so very loving and kind. So over to you, Dr. Maushmi.
Thank you, Surekha ma'am, for your so kind words. And at the beginning, I must wish all of you happy Doctor's Day today. And I consider it to be a proud privilege and great honor to be here as a guest of honor in such a platform with all my friends, very, very close friends. When Madhuri ma'am is here, and all my friends we have met so many times, and recently in Wisdom, we really enjoyed a lot. And now this is a wonderful webinar of Foxy Symbiosis series, the 15th one with the ICOG 3 points, and a joint webinar of Foxy Clinical Research Committee and the Foxy Infertility Committee with the Bhopal Obstetric and Gynecological Society. At the beginning, I must thank congratulate the office bearers. I've seen Madhuri ma'am so active, always smiling in spite of a very busy schedule. Dr. Chang, the president, is always there with us. Then Dr. Sharmila, yes, another friend of mine always smiling, Dr. Sureka Taide, the chairperson of the Clinical Research Committee of FOXY. We also had, BOGS also had some UNICEF program with you. Ma'am, we really enjoyed and listened webinar also. Dr. B. Kalpana, yes, another friend of mine, the chairperson of the Infertility Committee. Then the Bhopal Obstetric Gynecological Society, the president, Dr. Anita, the secretary, Dr. Shabana, then the convener of Foxy Symbiosis series, Dr. Manika, so active, called me in the morning and reminded me that, Mom, you have to be at this time. So thank you, Dr. Manika. Dr. Randhir Singh, the managing committee member. Then you have the program coordinators like Dr. Neetu, Dr. Purva, Dr. Nandini. And it is my great honor when Amit Patke is the chief guest and my another guest of honor with me in the same platform is none other than Dr. Sarveshwari, not here. So thank you, ma'am. You have galaxy of eminent faculties in this program and discussing on very burning and important topics like infertility research, then male factor, significance of DFI, poor responders, and a wonderful panel on ovulation induction. So wish all the best. I hope that all of you will be on us will be enriched with a lot of take-home message. Best wishes for the program. Thank you once again.
Thank you so much, ma'am. And Dr. Amit Patki will also join in about 1 minute. We are happy that our chief guest is joining and our guests of honor have addressed us so beautifully. Surekha ma'am has almost coordinated the program so beautifully with me. And I think by the time sir joins, is he here?
No, not yet.
Yeah. So, Dr. Kalpana ma'am, would you like to address us as committee chair, Infertility Committee? Dr. B. Kalpana is the dynamic chairperson of Foxy Infertility Committee, and it is her inputs with which we could, plan this program out. Dr. Vishal, can we have Madam CV? Yes. So I would like to do the honors and welcome Dr. B. Kalpana ma'am formally. We can see that she has a big role to play as infertility chairperson of Foxy, which is a subject very close to my heart. Madam has been very active in the Tapisar Society and the Madurai chapter of Tapisar. She has held various posts in TN Fog, as well as an active Isarian for 17 years with more than 2 decades of teaching experience in infertility and embryology. She is an active, very active and dynamic academician, has held several conferences, CMEs, workshops, and we can see she is expert at fertility enhancing surgery, laparoscopic radical oncosurgery, endosuturing and colposcopy with several publications of infertility in index journals. She's also the awardee of several awards, Best Committee Award, received from, TN Fogg under the Honorable Health, Medical Education and Family Welfare Minister of Tamil Nadu in 22, Badlav Appreciation Award from Dr. Rishikesh Pai, Rising Star of ISAR, Medical Excellence Award 2018 from Governor of Tamil Nadu, and of course, the Best Infertility Center she is running. So we welcome you, Kalpana ma'am, and like to have a few words from you, ma'am.
Yeah, thank you, Dr. Monica, for the kind introduction. It's a unique webinar combining 2 committees, FOGSI committees, Research Committee and Infertility Committee. Anyway, our president, Jaideep Tankser, couldn't join because of a program. He's held in a program in Calcutta. Thank you, Madhuri ma'am, for the wonderful message, blessings, and also information from FOGSI as a Secretary General. Dr. Charmila, our Vice President in charge, is always very friendly and guides us in a proper way. So we had wonderful message from Sarveshwari madam, senior most gynecologist from Central India, and also Maushmi, my good friend. We have really enjoyed your hospitality in wisdom. Thank you, Bhopal Society Office Bearers, for taking so much efforts. And we have our chief guest, Amit Patki sir, who had joined in spite of his busy schedule. I know as a president of ISA, he's held in so many programs, and even then he had joined, taken so much efforts. Sir, would you like to tell your message so that we will not waste your time?
A very good evening to you, and I bring you greetings from ISAR. Thank you so much for having me in this wonderful webinar, and thank you to Foxy and the Foxy committees. I have looked at the program and I find that the topics are very interesting and very pertinent to today's practice, right from ovulation induction to poor response, and excellent choice of speakers. So I think it's going to be a very, very educative program. And I wish all of you a very happy Doctor's Day. And I hope we continue to serve the women that we care for. And in infertility, I hope we are able to solve the problem of the couple. So thank you once again, and happy Doctor's Day to all of you, and the best wishes for this webinar. Thank you.
Thank you
Thank
so
you.
much, sir.
Thank you so much, Dr. Amit Patki, sir.
And also
Um,
we have wonderful faculties, in addition to committee chairs, Monica and Dr. Padmaja, who is going to moderate a wonderful panel, and Papa Desari ma'am is going to be the expert. Well-known faces are here: Dr. Umayal, Aneet, Sri Devi, Dr. Neelam Sinha, a good friend of mine. And also Neharika has also joined, Dr. Uma Shankar. So many good friends of mine are going to share their knowledge and make this wonderful webinar an academic feast. Thank you, Monica and Dr. Nandir, for organizing such a wonderful webinar with in collaboration with two societies of two committees of folks.
Thank you. Thank you, Kalpana ma'am. And before we begin the academic sessions, just a word of thanks to BOGS, Bhopal Obscurity Society. We have our president, Dr. Anita Srivastav, and we have our dynamic secretary, Dr. Shabana Sultan. So I think Shabana has joined. Shabana, would you like to welcome our guests?
Yes, ma'am. A very good evening to all of you, and a very happy Doctor's Day. I welcome all the dignitaries on behalf of Bhopal Obstetric Gynae Society, and I'm highly privileged to be a part of this 15th Symbiosis series, along with the Clinical Research Committee and with the Infertility Committee. And I think the topic chosen, they are excellent with excellent speakers, as always, with Monica ma'am's webinar. And all the very best to Monica ma'am for her webinar and for the future elections. And thank you so much, and happy Doctor's Day once again.
Thank you. Thank you, Dr. Shabana. You are a big pillar of support to all my academic activities. She's a great academician herself, as you will see and experience in the forthcoming big conference, national conference we are hosting in Bhopal, in which Dr. Shabana is the dynamic organizing secretary, and she has some wonderful scientific content ready for all of you. And with all our warm welcome extended to Dr. Surekha and Dr. B. Kalpana, Dr. Charmila ma'am, who will soon be with us during the this function. So I would like to thank my three sweet coordinators. We have Dr. Neetu Mishra from AIMS Bhopal. We have Dr. Purva Bhatkur from GMC Bhopal, the largest medical college in the city and the state, and Nandini Singh Bhati, again from GMC Bhopal. As you can see, this program is put together by three big medical college, they are consultants there. Still, they, put so much of time and effort in making this happen, in connecting with you, in helping me out. So I'll be forever indebted to their hard work and their dedication. So now I would like to even thank my co-coordinator, Dr. Randhir. And with your permission and blessings, we start the session 1. Over to you, Dr. Purva.
Thank you, ma'am, for your kind words. Now for the first session, which is on best practices for conducting clinical research studies in infertility. We welcome our chairpersons, Dr. Umayal ma'am, Dr. Niket sir, and Dr. Nivedita Jha ma'am. Dr. Umayal Murugesan ma'am is presently Secretary Kanjipuram Society, OBGY Society. She is presently Managing Director of Shri Kumaran, a specialty hospital at Tambaram, Chennai. She is active member of IMA and has held various executive posts in IMA. She is founding member of Tambaram OBGY Society. She is member of World Association of Perinatal Medicine, and her special field of interest are laparoscopic pelvic surgeries and reproductive medicine. We welcome you, ma'am. Next, we have with us Dr. Niket Patel, sir. Sir is presently Secretary Anand OBGY Society. He is director, consultant obstetrician and gynecologist, infertility specialist, endoscopic surgeon at Akanksha Hospital and Research Institute, Anand, Gujarat, and Zivia IVF. He has been awarded B. Nirmala Swami Gold Medal, and he is fellow in basic and advanced minimal access surgery and diploma in reproductive medicine. His special areas of interest are endoscopy, infertility, endometriosis, fertility preservation, and PCOS. We welcome you, sir. Next, we have Dr. Nivedita Jha, ma'am. Madam is presently Associate Professor, Department of Obstetric Gynae, Zipmer, Pondicherry. She is National Coordinator, Foxy Clinical Research Committee. Her special interest is in emergency obstetric and critical care, high-risk pregnancy, laparoscopy. She has various papers published in PubMed Index journals and is principal investigator of ICMR and WHO funded projects. She is editorial board member of BMC Pregnancy and Child Birth Thesis Guide and Undergraduate Examiner. She has been awarded Foxy Movicol Research Award 2023 and Foxy Women's Health Research Award 2024. We welcome you, ma'am. And now I hand over the session to chairpersons to introduce our guest speaker, ma'am, that is Dr. Surekha, ma'am. Thank you.
So, are the chairpersons there?
Nivedita is there, no? You can be brief. I'll just talk.
Nivedita, ma'am.
Nivedita, are you there?
Hello,
Nivedita?
yes, ma'am. Yes, ma'am. Good evening.
Hi,
I'm here. Yes, I'm here.
Please introduce Madam and her topic, Nivedita.
Professor Surekha, she is very dynamic. She is presently chairperson of Foxy Clinical Research Committee. And under ma'am, we have seen she is helping all of us grow and helping the society grow. That is a contribution to Foxy is immense. Ma'am is very well versed with whatever thing she undertakes. She is a researcher. And we have also seen many videos of ma'am. She operates very well, very interesting and difficult. She's a very good clinician. And in Foxy, I have been knowing ma'am last 2 years, and I follow her. She's my mentor in this field. So I appreciate her, and I'm really very much, I give a big thank you to all the organizers for giving me the opportunity to chair Surekha ma'am. She is a part of many Government of India funded projects. She's a mentor. She's a very good teacher, and words are less to describe ma'am in such short time. So I welcome you, ma'am, to present the topic on the types of research that can be done in the field of infertility.
Thank you, Dr. Nivedita. Thank you so very much. And my topic is best practices in the field of infertility. So best practices for research, that is my topic. And we did, have a lot of debate on what to keep, which will, be a bridge between the two committees. And that is why we chose this topic.
And it's a beautiful topic, Sureka ma'am. I don't think anybody has spoken on such a topic before.
No, no.
Yeah. So definitely when we are as a clinician, so I will speak both as a clinician and as a researcher. So when we are a clinician and we have to prescribe something, we have to make decision, like decisions between two drugs, which drug to prescribe, decision between medical therapy or surgery, which one is better. And when we are talking of intervention, what is the safety of intervention? How do you make these decisions? Now, these decisions can be based on three things. First, what is your clinical expertise in everything? What is your knowledge, your skill? Second is, what is the patient preference? And third and most important is, what is the evidence? What does literature say? What does research say about all these decision making, all these, aspects of clinical practice? So we are doing research to guide our clinical practice. We are aiming at research for decision making, and research is not done only for guiding our own selves to more higher post. It is not like that. It is because we want to know what is best with the patient, how does this affect the outcome of the patient. Thus, so
Slides.
okay, so yeah, slide now it is visible.
Yes, ma'am.
So when we are talking of research and we want to understand what type of research we should do, especially when we are talking of in context of infertility, we have to first understand the hierarchy of research. What are the various types of research we can do? Now, there can be two types of research. One is only descriptive, and another is when we compare and when we have some intervention. So descriptive, in the descriptive variety, we don't have any control group. There are case reports, there are case series, there are some prevalence studies which are done. Now, on the other hand, in the comparative type, the group, we have the observational type of research and the experimental type of research. So, in the observational, we have to remember that there is no intervention. Okay, the disease, the outcome has already happened, the exposure has already happened. There is no intervention as such. In this, three important type of studies are there. One is the cohort study, another is the case control study, and third one is the cross-sectional study. If we look at the experimental group, we want to know mostly about randomized control trial. So these experimental studies can be either a randomized variety or a non-randomized variety. Now, which again my slides are getting stuck. I don't know why. So let us look at a few of these studies and find out how we can contextualize in relation to infertility. Now, in descriptive studies, many a times we find case reports. And can we base our decisions on case reports? Now, case reports, especially, they will describe a rare condition or if your unexpected finding in a routine condition. So if you have a routine condition, something unexpected has happened. So these are sort of, warning systems, new disease, unexpected effect of a drug. You gave routine drug and something else happened. So yes, these are important because they tell us something about a rare finding, and you may not find that kind of event in any other variety of the study. So case report is also important. One of the example of case report in infertility is of a successful twin pregnancy in a 38-year-old woman suffering for ovarian insufficiency after autologous stem cell therapy. So when the stem cell therapy came first, so we have a 38-year-old with history of premature ovarian insufficiency presenting with primary infertility. Despite of number of IVF cycles with donor egg, she was not able to conceive. So as an experimental treatment, the autologous stem cell therapy was given to her. The stem cells were harvested, processed, injected into her ovary to rejuvenate the function. 6 months post-therapy, her hormone levels started improvement. She began regular menstrual cycle, and remarkably, she conceived naturally. Now, this, when you read this kind of case story, you come to know the highlights of an rare outcome of achieving a successful twin pregnancy in autologous stem. Now stem cells therapy has come up very nicely and in being taken up also in centers. But when it came as a novel idea, that is where a case studies will help you. So now what is a case series? Now, if you describe a number of subjects receiving the same therapy, suppose if we have 4 to 5 patients receiving stem therapy and you want to describe them and what is the effect, that is a case series. So they have to either receive the same therapy or suffering from the same disease condition. So that is a case series. Like I can give an example here. So this is an example of a analysis of 4 women who with POR premature who underwent ovarian PRP therapy. So previous one was for stem cell therapy. This is a patient. These are 4 patients who went through ovarian PRP. So you have to describe what happened, what were the levels, what happened post PRP, how the AMH increased, how the FSH, values reduce, and whether they conceived and by which method, naturally or IVF or donor egg or whatever. So then, a clinician who is reading your case series is able to gain something from you. Okay, this is the way a patient can be treated. So these are, case series and case reports are especially for rare events or novel events or something, you find out new, but the data available is small. You cannot do a original study on it. So all these are descriptive studies. There is no comparison, but you just describe something and you find out, you interpret and you give a result or conclusion, which can be followed by clinicians who are reading your case series or your case report. Now let us look at comparative studies. Now, if you see, I would just like you to focus on the study direction. Many a times, even seniors or professors, they have this problem of what is a cohort study and what is a case control study. So you have to look at the direction. Where is the study progressing? So if you have an exposure and you have a group of study participants, which we call as cohort, and there is an exposure, the study moves forward and then you have an outcome in the future that is called as a cohort study. So you have an exposure, you follow the group of cohort, and then you have an outcome. Now suppose you already have an outcome, like an ovarian cancer is there, you want to go back in the retrospect and find out what happened in the past. So you have a cases, you have a control, you have an outcome, and you go back to find out if there was an exposure. Suppose for ovarian cancer patients, you are trying to find out if there is an exposure of OC pills, something like that. So that would be a case control study. Now, what is a cross-sectional study? Means it is just a section in the time, just a snapshot you want to take. You are neither going back, neither going in the front, neither retrospective, now prospective. Just you are trying to find out what happened in the present. That is the simplest way of describing a cross-sectional study. Now, let us little bit go into cohort study. Now, this is an example to investigate the potential long-term consequences of the use of oral contraceptives. This is the design. 122,000 married registered nurses were enrolled in the study to be followed prospectively for 2 years. So you have enrolled the women as a cohort, following up to 2 years, and you are now dividing the population into OC users and non-users and finding out what is the effect of these OC use on chronic illnesses like DVT or breast cancer or any other outcome. So this is one example of a cohort study. So here a group of subjects with your condition of interest, and one group is exposed Another is without the condition, they are followed up in time. So one is your cases and other your control, and the frequency of outcome in the two groups is then compared. So I hope everybody understands that here in the cohort study, there is an exposure and outcome, and what we calculate is the relative risk. Okay, so you have an exposed group and you follow them and you find out the percentage of the outcome, and then you compare the two and you find out the relative risk. So that's the difference. People, they are not able to understand which study has the relative risk and which study has the odds ratio. So when a cohort study, you always calculate the relative risk. Now look at this clinical scenario, 32-year-old with oligomenorrhea. She's complaining of subfertility since 2 years. Intervention is the clomiphene citrate. And you want to know, if you give a clomiphene citrate, is there any chance of having a higher risk of having a anomalous baby? So what kind of study you can do? Now, if you want to do this kind of study, you have to first and foremost, define the PICO. What is the patient population? What is the intervention? What is the comparison? And what is the outcome? Here, your population is a 32-year-old with subfertility, oligomenorrhea. Intervention is your clomiphene citrate. Comparison is women not using clomiphene citrate. And outcome is you want to find out whether there is a possibility of higher risk of congenital malformation in women suffering from your women prescribed CCs, that is your clomiphene citrate. So here you can see 935 children born in this group. Here 30,000 children born in the spontaneous group. Here there were 21 congenital malformations. Here there were 520 malformations, which is only 2.2% here and 1.7 here. So if you just look at it, you will think, oh, 2.2 is higher than 1.7. But that is not the case. You have to apply the statistical tests and you will know probably this is not a significant difference. The difference between the two is not significant. So we can conclude easily that the clomiphene citrate doesn't cause a higher risk of malformations. That is what you conclude. So when you have two percentages or two outcomes, what you have to do? You have to apply the test, comparative test, and find out whether the difference which is seen is just by chance or there is a statistical significance to that difference. Now, what do you do in the case control study? You have an outcome, you go back and find out if there is an exposure, and then you find the odds ratio of the exposure for the case and for the control, and that is how you calculate the odds ratio. So for the cohort study, we are using the relative risk, and for the case control study, you have the odds ratio. That is how you express the outcomes in these two studies. So here you can see these are very old studies. One is from a case control study, another is the cohort study. Whitmore, he found his cases were women with ovarian cancer, controls were women those who are not having ovarian cancer, and exposure was the fertility drugs, and they found out that the risk increased in these patients, in women who were taking fertility drug. But there is another study done by Wen, which was a cohort study. That is a prospective studies. Cases for those having IVF treatment, control who did not have IVF treatment, outcome was ovarian cancer. And they concluded that the risk was similar in both the groups, those receiving the IVF treatment and those not receiving the IVF treatment. So how do we decide? So one study went back and found out whether fertility drugs were taken or not. Another study went forward and followed up these women who had subfertility and concluded that the risk for ovarian cancer was similar and there is no need to worry if you are undergoing fertility treatment. But when you are comparing these studies, we really have to look at the sample size, what analytic tests were used, and how the study methodologically, if it was correct or not, and then only as a clinician we should rely on these studies when we are using the outcome of that study, whether the conclusion is we can take, or is it a valid conclusion. So that is how you also have to design your own study. Now cross-sectional studies are a snapshot in time. Neither go in front, neither you go in forward. You just try to you have the cases in front of you, you have the controls in front of you, you just find out the percentage. So it is a percentages and proportions. That is how we are so here is a cross-sectional studies parameters of ovarian blood flow distinguished between women who are ovulating and those who are not ovulating. So it is just a cross-sectional study, but we are comparing between two groups. So you do have a comparison here, but you are not having any exposure. Okay, and here the conclusion is there is a difference in ovarian blood flow in anovulatory versus ovulatory women. The alterations in blood flow in anovulatory women may contribute to anovulation. So even if you do a cross-sectional study and you have a proper comparison, then you can make good conclusions. Not necessary that always you have to do RCTs only. Okay, so even good cross-sectional studies can be done if we have defined, well-defined comparative groups. Okay, so cross-sectional study is in which the exposure and outcomes are studied simultaneously. However, here we cannot determine the cause and effect relationship. Like we say, smoking causes lung cancer. That is cause and effect relationship. That we cannot determine in a cross-sectional study. Now, let us look at the experimental studies. All experimental studies are prospective. We do not do experimental study in the retrospect. We have to always go forward. You have your intervention to do. So that's always done in the prospective. And there are two types of interventional studies. One is the randomized controlled trials and the other is the non-randomized. You are doing the trial, but you are not randomizing. So here you have the experimental group, which again, you find out the outcome and the investigator will decide who gets the intervention and who does not get the intervention. Okay, and if you randomize it, then it is called as a randomized trial, and otherwise it is a non-randomized trial. So always when you're doing a research, you have to think, is there a control group? If there is no control group, then it is a descriptive study like a case report or case series or prevalence study. If there is a comparative group, did the investigators determine the intervention? Did they themselves do the intervention? Then it is a controlled trial. It is called as a trial. So if you are doing an intervention, if there is no intervention, then it is just an observational study. Look at the study direction. If the study direction is forward, it is cohort study. If it is backward, then it is a case control study. Now, when you are doing the intervention, was the allocation of the intervention a random allocation? If yes, then it is a randomized controlled trial. If no, then it is a non-randomized controlled trial. You can still do because see, if you are a surgeon and you are doing an intervention, like if you are giving a subcutaneous, one is giving subcutaneous stitches and another is giving mattress stitches. Can you randomize? No, because that surgeon will know what he has done. So it is not necessary, especially surgical interventions cannot be randomized. But if you are giving some drug or some other intervention, these interventions can be randomized. So both each kind of study has its pros and cons. Okay, this I have already explained the direction of a clinical study. But at the end, when we look at the hierarchy of research, the randomized controlled trials are considered the gold standard of research. Now, this is one example. Some fertile men with varicocele, R1, R2. So, this is the randomization. How do you randomize? one will get the surgery, other group of men are not getting the surgery for the varicocele. What outcome we are looking at, whether there was a pregnancy or not, and then you are determining whether the surgery is required in a man who is having varicocele, okay, to gain a good pregnancy outcome. So here you can see direction of research is prospective. Now, why these RCTs are at the top? Because they appropriate, if you conduct adequately, they give almost the true result, which can they reflect the result of the population. So though you use a small sample size, but you can generalize it to the population because you have done randomization, you may have done blinding as well, so that your research does not have bias, does not have confounding factors. Hence, a randomized controlled trial, is considered the best at the top of the hierarchy. Here you can see participants. They are randomized as randomly assigned to two groups, intervention group, control group, and the follow-up is done and the outcome is compared. That is the anatomy of an RCT. Golden rule in scientific research is both the intervention group and the control group should be almost similar in all aspects except the intervention. Thus, they have to be similar, and only that intervention is different, and that is how you can get. Now, in this group, look at this group. Effect of metformin on infertility in women with PCO. Group 1 is having CC with metformin. Group 2 is having only CC. Here there is 50% pregnancy rate. Here there is 35% pregnancy rate. Do you think this is a good study between the cases and control? What do you think? Is there some bias in this study?
Yes,
Anybody
yes,
can...
biased study, because the group 2 is obese women and group 1
Yeah,
is the
so
athletes.
definitely these are the confounders. So you already have a confounder which affects the pregnancy rate. So these two groups are not similar, and thus what result you are getting is cannot be attributed to your intervention, which is metformin. So when you are comparing, your groups have to be similar. So if these women are obese, these women also have to be, the BMI categories. Now here, look at this. Effect of two HRT regimes on osteoporosis. One group regime 1, another group regime 2. One group is smoking, drinking tea. Another, you are not allowing smoking. They are very active. They are having sports. Is it comparable? These two groups are not comparable. Already the confounders are existing. Have to remember that both the groups have to be similar in their descriptions, in their demography and their other attributes. Only that one intervention has to be different. Then only you can, compare the outcome or attribute the outcome to the intervention. Now, what are the methods of randomization? You can just toss a coin and, there is rolling of a dice. But what we use, random number tables. You can use computer generated table. There can be blinding as well. Now, in the last aspect, I will be telling you about how to design a good randomized control trial, especially in context of infertility. First of all, you define your PICO question, PICO format, which we say is the population. Suppose infertile patients with PCO. What is your intervention? Intervention, metformin plus formamifene citrate. What you are comparing with? Only clomiphene. What is your outcome? Higher pregnancy rate. So you define your PICO first, then you define what is your inclusion criteria. These are infertile women having PCO. Now from this, you have to exclude some of the women. This could be age more than 40, who already had drilling, who had diabetes, etc. So define your inclusion as well as your exclusion criteria. And then, of course, you go and define the sample size, depending on what is the prevalence of PCO, you will get a sample size. So correct sample size is also very important. Then you define your outcome. What is your primary outcome here? Pregnancy rate. What is your secondary outcome here? It could be ovulation rate, it could be side effects of CC or metformin, it could be abortion rate as well. So you have to define all these things prior to your study. So primary outcome, secondary outcome. And then of course, you have to, another example I'm giving. So suppose this is the current practice of ovulation induction in IUI patient. You are giving clomiphene citrate followed by HMG or FSH. Now, novel idea. You have an idea in your mind that if you give HMG or FSH prior to clomiphene citrate, it may help better. Why? Because some cases are CC resistant. Some 25% cycles get cancelled because of premature ovulation surge. This is the idea in your mind. You have a rationale in your mind. And you believe that if this turns out to be true, use of HMG at start of cycle for few days will avoid CC resistant cases first of all, and using CC till the date of HCG trigger will avoid premature LH surge. This you have read in literature, you have a rationale in front of your mind, you have a scientific reason for doing it, you have a reason that anti-estrogenic effect may prevent premature LH surge while maintaining a positive influence on the follicular development if continued till day of HCG. So you have a rationale, you have a scientific basis, and then you have to determine the outcome parameters. Here the outcome parameters are clinical pregnancy rate. So you should know there are two types of pregnancy rates. One is biochemical pregnancy rate, another is clinical pregnancy rate, which is determined by ultrasound. And of course, your parameters can be premature LH surge. Secondary outcomes also have to be defined, and you have to do the study. How to do a sample size calculation? You need to know the prevalence. So you have a formula. In that formula, you have to add what is the prevalence, what is the power of study you have to find, and then you can calculate. You do have calculators on the net also, which can give you a proper sample size. So you should have a proper sample size also when you are planning a RCTs. Once you have a sample size, you have to, compensate for the dropout as well. So if you said my sample size was 95 and you enroll only 95 women and 10% of them did not come for the treatment or just dropped out from the study. So you have to compensate for the discontinuations also. And if there is more than 10% dropout, then it affects your validity as well. So this is your novel protocol. You want to give HMG prior to CC. So you give HMG and then you follow it up with CC and you find out the outcome. And your original control group was who received only HMG, no CC. Okay, so this is how you plan your study. These are the results. Now in RCT, you remember that other factors like age, demographic factors have to be similar. That means your p-value will be not significant. Like in this case, the average age, the duration of infertility, the cause of infertility, everything was similar in between even the BMI was similar. The number of cancelled cycles, everything else was similar. What was different was how many follicles were more than 16 mm size. So as you can see in the combination group, you found that you have more number of follicles above 16 mm with a p-value 0.05 less than 0.05. Number of patients with premature LH surge were more in the HMG group. So that is again a significant finding. How did you say it is significant? Because you compared the two by statistical test. You find the p-value. P-value was less than 0.05, and that is how you determined that this is a good protocol, especially for younger women, those who are having unexplained infertility or those who are having male factor infertility. So that's how you decided by doing an RCT. Yes, so unless you have similar comparators, you are not able to do that. Now, again, I'll give just a few examples of what studies have been done in infertility and what simple conclusions have come out. Now, this is one conclusion. Postcoital test. Conclusion is, do not use routine postcoital testing of cervical mucus as it has no predictive value for pregnancy outcome. Another study was done, medical and surgical management of male infertility. So conclusions are, men with hypogonadotrophic should be offered hypogonadotrophic hypogonadism should be, only these men should be offered gonadotropins. Other men who are having idiopathic semen abnormalities should not be offered anti-estrogens, androgen, bromocriptine, kinine enhancing drugs. We can see in practice, all men are offered everything, you know, but that should not be the practice. Only those who are having hypogonadism, they only should receive gonadotropins. Another study, gonadotropins for idiopathic infertility. So this was compared to placebo or no treatment. Gonadotropins showed a significantly higher pregnancy rate. So if you have women, if you have couple with idiopathic infertility, even then gonadotropins will help, and this has been already proven by an RCT. Surgery for varicose. Should we do or should we not do? What do RCT says? Do not offer surgery for varicose. There is no improvement in the pregnancy rate. Already proven, study has been done, RCT has been done. Factors affecting outcomes. Women with hydrosalping should have laparoscopic salpingectomy is the conclusion. Natural cycle IVF is not recommended. Assisted hatching should not be routine except for women over 38 years. So we have various guidelines available as far as infertility is concerned, and most of these guidelines have been based on randomized control trial, well-controlled study with good. Now, for ET, I'm not going to talk about this because you people are better. So the last message from my side is, choosing the right study design is important. Defining the PICO format is critical. Sample size have to be appropriately calculated. You just cannot say 100 patient, 200 patient, 50 patient, not like that. It depends on a certain formula, the prevalence of the condition. Method should be detailed and based on scientific rationale. Appropriate statistical analysis will give a good validity. Why you need a good valid study? Because you want to generalize it to the population. And of course, our city is the boss of all studies. So over to the chairpersons.
Thank you very much, Surekha ma'am. It is a treat to hear you. And you have taken the topic so beautifully well. I must appreciate your depth of knowledge. So the topic for people who joined late, it was the types of research studies which can be done in infertility. And ma'am has spoken, like whenever we want to do a study, we should first think of the research question. What question, what we want to do exactly. And that should be done on the PICO format. Population you have to define, intervention, your comparator and outcome. If this is done, half of the study is done. Next, we move on to we decide the proper methodology and study design. So of all the study design, randomized control trial, all of us should attempt because that generates the best level A evidence. And yes, sample size, a well-referenced sample size, a good sample size will definitely take us, will scale the study to a great height. And ma'am spoke about all the appropriate study designs, and she gave beautiful examples. So of the studies which have been done, and some things like, it was so many new things I learned today from ma'am's talk. So everything is because, studies have happened. And now I have a list of topics which I searched today that still in infertility, these topics are being done or not very much done across globe. So these are the thrust areas of research in infertility. And I wish if Foxy Clinical Research Committee and Infertility Committee could come together on a platform and we design a proposal and do one of these studies together. So about safety of treatment in infertility is not well researched. Even mental health, psychosocial well-being of women with infertility, healthy habits, success rate of ART, and alternative and supplemental treatment. Yes, that is also in vogue, and even ICMR, they are accepting many of these studies where whether alternative treatment, does it really help in the management of infertility. Then quality improvement study, every center should have its own data regarding the quality improvement study on service provision. Then yes, RCT, the most important, helps us optimize treatment regimens and protocolize treatments that can be done with RCT, and the best drug and the best treatment can be instituted to the patients. And one more area which is not much research in infertility is the factors that may predict treatment outcome. So this after my some bit of reading to prepare for today's webinar, I found, and I wish we could do this together. And thank you very much, Monica ma'am, for inviting us. And I mean, nobody else could have taken this topic better than Surekha ma'am. So thank you, both of you, and thank you to the organizers again. That's it from me.
Thank you, Dr. Surekha. Whatever Nivedita has said is totally true. Nobody could have done the justice to this topic as much as you have done. And you have just not taken the slides and read them. You have properly put in examples from infertility, male infertility, female infertility, hydrosalpinges, arbitrary medicine, add-ons, clinical outcomes. And I think it's like Nivedita, we have revised our whole of BCBR again, you know? So it's like it's very nice because I basically like methodology, clinical research methodology. It's one of my favorite topics. So I thoroughly enjoyed it. And definitely, if any ART practitioner needs to consistently give good results, they just cannot deviate from research methodology. And as you will hear in my talk, it is all about guidelines which are evidence-based and those which are going to go out. Thank you so much. And thank you, chairs. Thank you.
Thank you, ma'am.
Thank you, Surekha ma'am, for your wonderful session. Now moving forward for the second session, that is on male factor and the significance of DFI. I invite chairpersons Dr. Reena Ahuja ma'am and Dr. Sridevi Velanki ma'am. Dr. Reena Ahuja ma'am, Madam is presently President Dehradun OBGY Society. Madam is Senior Consultant Jan Kalyan Hospital Dehradun, Member Foxy, Member IMA Dehradun, President-elect Association of Obstetric and Gynecology Dehradun. She has various achievements. She is gold medalist and has been awarded President Award for Best Undergraduate Student, Super Doctor Award by Honorable Governor of Uttarakhand, and she is eminent speaker in RCOG and other national conferences. Her area of interest are high-risk pregnancy and infertility. We welcome you, ma'am.
Thank you so much. Thanks so much.
Next, I welcome Ji ma'am. Ma'am, you were saying something?
No. Please carry on.
Next, for chairing the session, we have with us Dr. Sridevi Velanki ma'am. Madam is presently President Vijayawada, Consultant Obstetric Sri Vijaya's Maternity Hospital Vijayawada. She is past VP of Vijayawada Society and is First Lady Honorary Secretary IMA Vijayawada. She has held various executive positions in IMA and has organized various conferences. We welcome you, ma'am. And now I hand over the session to chairpersons to introduce our speaker, madam. Dr. B. Kalpana, ma'am.
Good evening, dear colleagues and friends. It's a proud privilege today to be present among you all and to introduce Dr. B. Kalpana, who is presently the chairperson of the Foxy Infertility Committee for the year 24 to 27. She is the president Madurai chapter of TAPISAR, past founder secretary Madurai chapter of TAPISAR, and peer reviewer Jogi. Apart from many feathers to her cap, she's also an active ISAR member for the last 17 years, and she has organized more than 200 conferences, CMEs, and live hands-on workshops. You are welcome, ma'am, and please enlighten us about this such a useful topic which is a new kid on the block for male infertility. That is sperm DNA fragmentation, which will improve the evaluation of male infertility. Dr. Kalpana, please.
Yeah, thank you, chairpersons, for the kind introduction. Actually, I didn't notice that the topic had been given 30 minutes. As usual, I thought it is 15-20 minutes. And anyway, DFI has, we all know that it is a debatable topic. And when we think about DNA damage to the sperms, it can happen during spermatogenesis or during its transport through the reproductive tract. Sometimes it is augmented by our centrifugation during semen processing, sometimes during cryopreservation. So obviously it has been proved by various studies that in infertile patients compared to normal controls, DNA fragmentation is. So the next question obviously that comes to our mind is, does it impact the pregnancy rate? It's a debatable question. And now should we go for DFI testing to all of our couple going for infertility treatment, or should we selectively go for DFI testing for a selected group of patients? So we need to know when to do, what to do, and how to treat is again a debatable topic. So what is DNA fragmentation? Is a damage to the DNA strand, either a single strand or sometimes double-stranded DNA is damaged. Sometimes it is deletion of a base, which can also manifest as various presentations. Normally, during spermiogenesis, what happens, the package of glutamins, in addition, some of the histone residue is also incorporated, almost 15%. So in normal fertile male, protamine dominates and protamine histone ratio is very high. Sometimes in infertile couple, infertile male, histone dominates and sometimes even 100% protamine deficiency had also been found. So what happens? This DNA is sensitive for ROS damage. So we can see mainly it is dominated by protamine. Only 15% is histone in the sperm cells. So what happens if the DNA is damaged? It is really peculiar for the spermatozoa that it cannot undergo repair mechanism. So it is persistent to its lifetime, and its impact is there on the reproductive potential for its lifetime. So how is it happening? So what are all the reasons for DNA fragmentation or DNA damage? It could be due to abortive apoptosis. That means few sperm cells are undergoing apoptosis process, but ultimately they couldn't complete the apoptosis. So, endogenous endonuclease release the fragmented DNA into the system, which can ultimately damage the fertility potential. And abnormal chromatin packaging could be a reason where this less densely packed chromatin is sensitive to reactive oxygen species. And normally, reactive oxygen species is present in natural atmosphere also, but it is balanced by on antioxidative measures or substances present in the system. So normally ROS is really needed for oocyte-sperm interaction and also acrosomal reaction facilitation. For all these things, minimal amount of ROS is really needed. But when the ROS is exceeding the cutoff level, where it can be compensated by the antioxidative measures or substances in the system, then the problem arises. And sometimes the reactive oxygen species is increased by various mechanisms like our lifestyle. Aging is an important factor, obesity, smoking, alcoholism, varicocele, sometimes infection can precipitate increased levels of ROS. So, environmental pollution is also, but ROS, the damage is at various places, starting from epididymis, vas deferens. So, sometimes even during semen processing, the ROS level is increased with our routine processing, where we include always centrifugation, which increases reactive oxygen species. Sometimes this is a study published in Fertility Sterility, which concluded that in fertile male, after processing, semen processing, definitely motility is increased significantly, but DNA damage is not very significant. You can see 8 plus 2 initially and 9, which is not very significant. But similar centrifugation in infertile patients, yes, motility is significantly raised, but at the same time, fragmentation is also significantly increased. So not only motility, but DNA fragmentation is also increased when we take the sample for centrifugation. So we should be little careful in the selected group of patients. So now, how to test for DNA fragmentation? We have various tests available in the market. One is direct test, tunnel test. That is labeled nucleotide is mixed with a semen sample, which usually binds to the nicks or damage in the DNA of sperms and gives us fluorescence. So with that, we can come to a conclusion about the percentage of fragmented sperms. So the other methods are sperm chromatin structural assay, where acridine orange is used. Normal sperms will give the green fluorescence, and fragmented sperms will give red fluorescence. The ratio of red to green will give us the amount of sperms which had been denatured or fragmented. Another simple test is sperm chromatin dispersion assay, otherwise known as halo test, where the sperms undergo denaturation. If the DNA is not fragmented, it will give us a halo around the sperms. If the halo is absent, that means the DNA is fragmented. We also have comet assay, which is an electrophoresis, where the normal sperms reach the head of the comet and DNA fragmented sperms will reach the tail of the comet. So we come to know the amount of fragmented sperms. So almost all these tests have strong relationship, and sperm chromatin structural assay is always better. But it is also modified by the mechanism or by the method by which it is tested. Usually 2 to 5 days of abstinence. After that, it is tested, and testing is done within 30 to 60 minutes after liquefaction or immediately after thawing. This guideline is given because once it is stored for a longer time, after 4 hours of collection or after 4 hours of thawing, it has been documented, studied, and concluded that it increases DNA fragmentation. This is a study published in Fertility Sterility, which concluded that if the frozen thawed sample is taken, DFI is 16, and 4 hours after thawing, it is almost 29. So to come to a conclusion about the result, to avoid any flaws, the test should be done immediately after thawing, or at least if it is a fresh sample, almost 30 to 60 minutes after liquefaction, it should be done. So how important is this fragmentation? That again depends on the type of fragmentation, site of fragmentation, extent of damage, and number of cells affected. And is it compensated by the oocyte, or there is already there is some problem in the female, and female age is higher, the female oocyte cannot compensate the DNA damage, and processing technique will also influence DNA fragmentation. So what is the relationship to infertility? It has been clearly documented by this fertility sterility paper published recently, which concluded that infertile male DFI from 13 to 25 in infertile population, and it is significantly increased. Even in tunnel test, it is documented in the similar way. So it is true that DNA fragmentation is relatively higher in infertile population compared to fertile males. So first society to advocate SDF testing was Society for Translational Medicine in 2017. Will it interfere with the semen parameters is the next question. So various papers, even though there is little controversy, majority of evidence is towards its impact on semen parameters. Yes, it can cause oligospermia, various papers, almost 3 papers in favor of it and 1 paper, no conclusive evidence. Teratozoospermia, yes, it is possible. In 4 papers concluded that and 2 inconclusive. Asthenozoospermia, again, 4 studies RPTs concluded that the parameters may be affected. So what about pregnancy rate? This is the paper published recently, which concluded that if DFI is less than 27, the chances of pregnancy are significantly higher. This cutoff level varies from study to study, and few concluded that even with 20% as the cutoff, if it is more than 20%, pregnancy rate is affected, and if it is less than 20%, the pregnancy rates are not affected. But Yeshre concluded that if DFI is more than 30, that means excellent potential, fertility potential, if DFI is less than 50. But if it is more than 30, worst fertility potential. But if it is between 15 to 25, good, reasonably good. If it is between 25 to 30, fair fertility potential can be considered. This is the guideline from Yeshri. So obviously, if DFI is less than 15%, 85% of males would conceive in next 3 weeks. But if it is more than 30%, definitely only 20% of males can conceive in the near future. So it is definitive that it may impact the fertility potential of the male. So what is the incidence of DFI? How common is this DFI? In general population, when we take the incidence is 1 to 4%, but in infertility patients, it is significantly increased. When we take IUI group, it is almost 7%. When we take IVF patients, it is 16%. And when we take HC group, it is almost 33%. So now should we go for testing, and will it predict the pregnancy rate? Because it is not the male factor alone, because many a times it has been compensated by, even though the sperm doesn't have any repair mechanism, but when the fusion happens and oocyte can repair the fragmented DNA. So ultimately, the prediction of pregnancy are really difficult, and the correlation is not very strong enough. So this study concluded that the do sperm DNA integrity test predict pregnancy in vitro fertilization. It is not strong enough to provide a clinical indication for routine use of these tests. So, does it affect fertilization, embryo quality, pregnancy loss? We have controversial results from various papers about fertilization. We have 19 papers. Out of that, 8 concluded that, yes, there is an alteration in the fertilization rate. At the same time, 11 papers concluded that there is no significant alteration in the fertilization rate. And what about embryo quality? Is it fragmented embryos and poor quality embryos do we get with the DNA fragmented sperms? We have 18 papers. Out of that, 8 concluded that, yes, there will be some impact on the embryo quality, but 10 papers concluded that there is no significant impact on the embryo quality. What about pregnancy? When we have 21 papers, out of that, majority concluded that there is an impact on the pregnancy rate, and controversial reports also we got from 9 papers. So when we think about pregnancy loss, again, the controversial results from various authors. So this is a systematic review and meta-analysis about DFI and pregnancy loss after IVF and ICSI. The author concluded that the pregnancy loss after IVF ICSI is significantly increased in sperm DNA damaged when the DFI increased sperms are used for IVF or ICSI. So when we have fragmented embryos, it is not, let us not blame the sperm alone. Sometimes it may be oocyte factor. So let us consider all those things. But the fact is the fragmented DNA from sperm is compensated or repaired by oocytes mechanism, repair mechanism. So this is a study published in Fertility Sterility, which concluded that if DNA fragmentation is increased by 10%, the pregnancy rate comes down by 1%, especially in DNA fragmented sperms. But if the same DNA fragmented sperms are used in donor oocytes, which is considered to be normal, there is no significant impact on the pregnancy rate. That means competent oocytes can compensate the fragmented DNA and repair mechanism, and pregnancy rate is not significantly affected. So what is the conclusion from large database reviews? This is the ESHRE guideline. Should we go for routine testing of DNA fragmentation for all males going for infertility treatment is a debatable issue, but this the association between DFI and recurrent pregnancy loss is quite strong, and there is significant increase in recurrent pregnancy loss that has been studied and concluded by various reviews. So ESHRE also concluded that it is recommended to go for DFI in patients with recurrent pregnancy loss. But at the same time, ESHRE concluded that it is not even in patients with recurrent implantation failure or IUI failure, it is not recommended to go for DNA fragmentation test. This is the conclusion from ASRM, which concluded that routine DFI is not recommended at the initial evaluation, but if the patient comes to us with history of recurrent pregnancy loss, we should advocate a DNA fragmentation test routinely for these patients. So even though ESHRE do not recommend routine testing of DFI for all male factor, European Academy of Andrology concluded in its guidelines in severe OAT patient going for ART, it is advisable to go for DFI. European Association of Urology concluded that in unexplained male infertility, if then DFI can also be considered in these patients to improve the outcome. So coming to the treatment part, obviously the factors which would increase DFI should be corrected, starting from obesity, lifestyle modification of avoiding smoking, alcoholism, treating male genital tract infection because the ROS level will be controlled, and very clinical varicocele, if it is there, correction of it would reduce DFI. All these modifiable factors can be corrected. And about antioxidant therapy, even though we have been using routinely, the literature evidence is not very supportive, and ESHRE concluded that antioxidants will not increase live birth rate. At the same time, we have been, there are various papers which concluded that repeated ejaculation can help us to reduce DFI in these patients, and semen preparation techniques should be modified by microfluidics, which doesn't have centrifugation. So the DFI index is not increased by our centrifugation. ICSI is always better than IVF in these patients, because when we go for IVF, that increasing denatured DNA can cause fragmented embryos. ICSI, we are just selecting single sperm and injecting it. That would be always better. If that also fails, few authors had recommended testicular sperms because it is not exposed to ROS of reproductive tract. So, to conclude, it is definitive that infertile males have higher DNA fragmentation index, and sperms of infertile males are more susceptible to reactive oxygen species. And the oocyte repair capacity cannot be measured, and that again depends on female factor. So no routine, it is not recommended to go for routine testing of DNA fragmentation index for all the patients. If there is a suspicion, semen processing technique should be altered. Sperm selection technique should be a modified one like microfluidics to avoid centrifugation induced DNA fragmentation index. ICSI is always better in these patients. So again, it's a debatable topic. We need to wait and watch for further conclusion from larger database reviews, so we can go for routine testing in patients with recurrent pregnancy loss, and all these alteration lifestyle modification should also be considered. Thank you.
Chairperson's comments, please. Sridevi ma'am, you're muted. Sridevi ma'am, you're muted. Madam, you're muted.
Yeah, it was a very well presented topic, touching upon all the trials and all the studies. You have very well enlightened the significance of DNA fragmentation on the male factor and the causes for recurrent implantation failures, and the need, you have also emphasized the need for more studies before we can come to a conclusion. Any questions are welcome.
So, madam, are you doing DFI routinely for your patients, or you are having certain criteria, some semen test criteria wherein you advise DFI, or do you do it before every IVF and ICSI?
Not before all IVF ICSI, but in severe OAT and recurrent pregnancy loss, definitely we go for DFI. And honestly speaking, we have been using antioxidants, even though the literature is not supporting us, but it doesn't harm the patient. So we have been using, everyone must be using, I think. So we have been using antioxidants. Selectively, we are doing DNA fragmentation, yes, for RPL, but in OAT also.
So, madam, you prefer antioxidants per se, or CoQ10, or a combination of both as add-ons?
CoQ 300 we prefer.
Okay. Ma'am, there is this role of frequent ejaculation. Do you
We have been using that also. If BFI is high, we take second ejaculation, and we prefer ICSI in these patients, testicular sperm as a last resort. If the patient fails in that also.
Thank you so much, ma'am. It was a lovely talk. It was a very, very elaborate and very informative talk on a less spoken subject, because I've rarely seen clinicians choosing male infertility as the primary topic of a talk in an infertility webinar. But you have done it, and you have done it brilliantly, so that it has, every time I hear about DFI, I feel that I should start doing it next day only. But somehow that in routine clinical practice, you have to inculcate these clinical methods, I think. Thank you so much, ma'am. Thank you. So I think we can proceed. Has Dr. Neetu joined? Dr. Purva?
No,
Ma'am,
ma'am, I
Nandini
will
will take
be.
over.
Okay, so Nandini, you can do this, start the third session.
Yes, ma'am. Thank you so much, ma'am. After an enlightening session, good evening, one and all. I would like to start with our third session. Our third session is on evidence-based guidelines on management of poor responders by our own convener, Dr. Monica Singh, ma'am. And to chair the session, I would like to invite our honorable chairpersons, Dr. Neelam Sinha, ma'am, and Dr. Kalyani Singh, ma'am. Dr. Neelam Sinha, ma'am. Dr. Neelam Sinha, ma'am, is the president of Muzaffarpur of Gynae Society. She has been a senior obstetrician and gynecologist and working in Sinha Nursing Home. She has been a senior professor at SKMCH Muzaffarpur and at RDJM Medical College, Turkey, Muzaffarpur. She has also been a vice president of Muzaffarpur Ops Gynae Society. She is a recipient of various prestigious awards such as Sadhana Dasari Award and recipient of Family Planning Award continuously 2 years in Muzaffarpur at district level. It's an honor to have you, ma'am.
Okay, thank you.
Thank you, ma'am. Our next chairperson is Professor Kalyani Singh, ma'am. Ma'am is the founder and president of Saharsa Ops Gynae Society. She is the emeritus professor as well as chairman of the Lord Buddha Koshi Medical College, Saharsa. Madam is also member of editorial board, Journal of Gynecology and Obstetrics Advancement and UK. It's an honor to have you, ma'am. Please enlighten us with your thoughts.
Yes,
Now,
I can.
now I request our chairperson to please introduce our speaker for today.
Okay, ma'am. I'm Dr. Neelam. It is my privilege to be chair this session, and I am very much thankful to the organizer of whole team and also Monica and whole team of the Bhopal Society. Dr. Monica Singh is an eminent gynecologist of Bhopal. She is the Vice President Bhopal of Gynec Society, Vice President Bhopal Menopause Society, Honorable Secretary MP Chapter of ISAR, West Zone Coordinator Medical Disorders Committee. She has past coordinator Foxy Infertility Committee and the Sexual Committee, organizing secretary 27th Annual ISAR Conference Bhopal. She has awarded for many awards and achievements she has got in her feather of the cap. ISAR draw
Thank you,
Natri
ma'am.
at
Madam, it's
ISAR
okay.
Bhopal 2023, a star of the Delhi Ishar Award December 2023, more than 20 international presentation, contributed chapter in the 5 textbook of the gynecology and obstetric, more than 200 national talks and presentation. So, honored Dr. Monica.
Thank you. Thank you so much, ma'am. Thank you very much for the honors, Neelam ma'am. I'm privileged to be chaired by my such senior chairpersons, Neelam ma'am. I'm really honored. Thankful to our committee chairs, Dr. Surekha Tarde and Dr. B. Kalpana ma'am. And my job has been made very easy because so many things have been spoken already about infertility research studies that I think my job has been made very easy. I'll just start sharing my slides.
सरमन को बुलाया
So I hope my slides are visible.
Yes, ma'am.
Okay. So I start from the beginning. My topic is poor ovarian response. So we have learned from Dr. Surekha ma'am a lot about evidence and how evidence can, control our knowledge about infertility, how it can guide us to do the best practice in medicine and in infertility as well. So first of all, we should know what is ovarian response. When we talk about poor ovarian response, we should also know what is a normal ovarian response. So this is actually the quality and quantity of follicular response and oocyte yield when we do ovarian stimulation. And the best way to assess ovarian response is by ultrasound scanning. By ultrasound scanning, you do serial measurement of follicle development, and you can also assess hormonal levels. But to be honest, I must say Dr. Padmaja is going to take panel. Nowadays, hormonal assessment is taking a back seat because ultrasound scanning has become so precise, crisp, and so highly developed that you can, easily assess the follicular development without assessing hormone levels and without subjecting the patient to extra cost or treatment. Whenever we do ovarian response, it is critical as a metric of success because the number of mature oocytes we get is strongly correlated with your live birth rate and clinical pregnancy rate. But there is a subpopulation of women. Despite doing everything, you do not get adequate success rate. And this is known as poor ovarian response because of poor follicular development and poor follicular quality. It was Gracia in 1983 who gave us first the concept of individualized ovarian response to ovarian stimulation. And this is very important because there is no blanket treatment for poor ovarian response. Every individual is different, and a 35-year-old lady might have very good cohort of follicles, and a 25 or 28-year-old might turn into be a poor responder. That is why the Bologna criteria were introduced in 2011, and they were put together in the ESHRE meeting of Bologna. That is why they were called Bologna criteria. And here the determination of poor ovarian response was based simply on any two of these three criteria. The first criterion was advanced maternal age or any other risk factor for poor ovarian response. This any other risk factor could be something like a previous surgery for endometriosis, a woman whose mother had had early menopause, or it could be a previous poor ovarian response. This woman had undergone IVF cycle wherein less than or equal to 3 oocytes had been obtained using conventional stimulation protocol. What do you mean by conventional stimulation protocol? These are those protocols where you use full conventional dose of gonadotropins. Or this woman had had an abnormal ovarian reserve test, and the two most popular ovarian reserve tests are AFC and AMH besides maternal age, where AFC less than 5 to 7 follicles added in both the ovaries, or AMH less than or equal to 1.1 nanogram per ml was counted as abnormal ORT or diminished ORT. Now, since I'll be talking about guidelines, my slides are moving on their own by auto mode, so I'll be, just speeding up for them. These guidelines are there to ensure optimum outcomes in every situation, especially poor ovarian response. But these guidelines do not ensure that, and the appropriateness of any specific therapy should be considered in on, the pretext of the patient's condition as well as the physician's choice and expertise, because there is known variability and biological behavior varies in different conditions and in different patients. But when these guidelines, which I'm going to speak about, were formed, they represented the best available data at the time of their preparation. But when we come to future research, then revisions might be made in these guidelines. Now, there is a burden of poor ovarian response, which we are facing day in and day out. And there must be hardly any IVF center in the country or abroad which does not face a poor responder every other day or almost daily. So the estimates of incidence is the number of new cases happening. This ranges from nearly 10% to 25%. Like every 100 patients coming to your OPD, 10 or every 1/4 patient is a poor responder. So whenever a cycle is cancelled in IVF, it is known as a cancelled cycle. That accounts for 1/6 of your total started cycles. Total initiated cycles, 1/6 are cancelled. And out of 1/6 of these cancelled cycles, nearly 50% are due to poor ovarian response. So this is the burden of the problem we are having. So there's always a smart way of doing things and there is a conventional way of doing things. So whenever we want to know the response, there is something called an ART calculator. AI is ruling us nowadays, and we are learning more and more about AI. So what is ART calculator? This is a clinical predictive model which estimates the number of mature or M2 oocytes which are needed to achieve that one elusive euploid embryo or blastocyst for transfer in ART couples. Now here it takes into account this calculator, the female age, the source of the sperm, like just now, B. Kalpana madam told us that whenever there is high DFI repeatedly, we go for testicular sperm. So the quality, the sperm source is important, whether it's ejaculate sperm or epididymal sperm or testicular sperm. And then you assess the success you want. Now, suppose you want a 90% success rate in such a woman, 33-year-old with testicular sperm, you will have to retrieve at least 11 mature oocytes in order to obtain one euploid blastocyst. So this is the calculator which will give you a a rough approximate idea. This is the classical picture of a poor ovarian reserve ovary. So I don't know what's happening. So this is a classical ovary of poor ovarian reserve patient. Here you are seeing very less follicles and you can even make out the ovarian volume with the help of 3D rendering. Coming back to the basic topic which I want to tell you about is the Poseidon criteria. Now, Poseidon criteria is something very, very important to understand. And this slide I'm going to talk about in detail because even for postgraduates and for clinicians, it is very important to thoroughly memorize Poseidon criteria if you're going to, deal with your infertility patients nicely. So this you can see is divided into 4 groups. The group 1, 2, 3, 4. It is made up in a grid of 4 and you can divide these 4 divide them vertically or horizontally into 2 groups. If you divide these 4 groups of patients horizontally, you get the group 1 and 2, which is the unexpected poor responders. These are those women whose AFC and AMH is pretty good. They have got an AFC of more than 5. They have got AMH of more than 1.2, as you can see. But still, when you start IVF for them, you find an unexpected poor response like a bolt out of the blue. You don't expect and you get a poor response. On the other hand, below the horizontal line, there is group 3 and group 4. And these are the women who are the expected poor responders. These are the women whose AFC and AMH are anyways low. AFC is less than 5, AMH is less than 1.2. And when you start stimulation for them, you know that you're going to get a good response, bad response or a poor response. That is why you will use the maximum dose for them. And anyways, you get a poor response. If you divide this grid vertically, on the left side, you get group 1 and 3. These are the younger patients who are less than 35, and group 2 and 4 on the right side, which are the older patients who are poor responders. So the maximum bulk of the patients are made up of group 2 and 4. This tells you one thing, that maximum patients of poor response walking into your clinic are the older patients. But this picture of this Poseidon criteria should be there either in your mind or, memorized or put in your consult so that you can know which category the patient belongs to. And there are some important definitions we should know before we start infertility practice, like what is the live birth rate, what is the ongoing pregnancy rate, what is the time to live birth, what is the multiple gestation rate. In very many countries, multiple birth is considered as a failure of IVF, and what is the miscarriage rates. It is only when we have an endpoint, like live birth rate is the most desired endpoint, that we know the success of our cycles, and that is what we aim at, whether the patient is a normal responder, poor responder, or hyper responder. So when we stratify poor responders, we naturally, I've already told you, have group 1 and 2, which are the patients who are less than 35 or more than 35, but they have got sufficient pre-stimulation ovarian reserve parameters, namely AMH and AFC, but still they land up with a poor response. And group 3 and 4, who are the patients with known poor ovarian reserve parameters, and that is why they land up with the poor response. This is how you stratify them, and this is how you treat them. So these criteria actually aid you in tailoring and optimizing the treatment strategies and guiding you. I think I will stop share and share again. Dr. Vishal, can you tell me why my slides are moving on their own?
Madam, in animation, you have to click the transition click करना पड़ेगा ऊपर, transition. Before, no, before screen sharing, you click the transition option and you have to stop the time. There is a timer in transition. Transition करके ऊपर in the sidebar ऊपर. There is a home, then there will be view, then transition, the animation. These various headings are there.
I think I have...
In your rehearsal time, you must have put the transition and the time for that in your PowerPoint.
So transition, you have to make it D-tick. Don't take the trans. Yes.
Yeah, so what I'll do, I'll stop sharing, and but when I share the screen, I have to...
In transition, you will be having advanced slide. In that, you make the time 0, duration 0, everything 0, and apply to all.
Yeah, but somehow, you know, this now, it's not getting minimized. End show. Yeah, I'll end my show, and I will go to my transitions.
In transition, at the extreme right, there is advanced slide written, advanced slide.
No, so can I make the transition? I'll make it disappear, the transition, on mouse click
None.
only.
Transition, you select, madam, none. No, any none. Not animation. You're talking of animation. I'm talking of transition.
I'm talking about transition only. Transition is on
There
mouse
is,
click now.
so transition, you deselect the mouse click, madam. No selection. Deselect both
so
the things.
Deselect.
Deselect.
Right. Okay, fine. I'll do that.
Deselect it, and after, below mouse click, it is written after. Also deselect that also.
No, it's okay. I think I should be able to do it. I'll start sharing. I'm so sorry for the problem. Yeah, I think it should be all right now. So I'll go to my slide share. And I think this was the last slide. So hopefully now it should be okay. These criteria, Poseidon criteria, are the criteria I'm talking about. They actually aid us in tailoring and optimizing the treatment strategies for patients with poor ovarian response. And they guide us in choosing the most appropriate interventions based on individualized patient characteristics. Here, we should not be using a blanket treatment for poor responders. Now, IFS has given us, Indian Fertility Society sat together and they gave us some very good guidelines for poor responders, which I thought would benefit every practitioner if inculcated into our practice. And I'm sure all fertility societies will, incorporate them sooner or later. When I made these slides, that time it was a draft document, but very recently IFS has come up with, a completely labeled document wherein they have, decided to publish these guidelines. They are available on the net. And there are certain points which I feel each one of us should follow if we want to give evidence-based practice to our patients. So one thing which we are always confused about is what is the value of hormonal testing which we do at baseline in predicting poor ovarian response. We do a gamut of tests like AMH and FSH and LH. Sometimes we do prolactin. So out of these, it is only AMH, which is a biomarker for predicting poor ovarian response and is strongly recommended as a hormonal test. Is there any role of ultrasound imaging at baseline? There are certain centers, especially in IUI cycles, wherein the patient is sitting at home and you prescribe either your CC or letrozole and tell the patient to come after day 7. So this is actually not advisable. And the use of basal AFC by transvaginal sonography for predicting poor ovarian response is strongly recommended as far as guidelines are concerned. Is there any value of genetic polymorphism testing in predicting poor ovarian response? Definitely not. Routine testing for genetic polymorphisms for predicting poor ovarian response is not recommended by the guidelines. And what about immunological testing at baseline? Again, there is no justification that you subject the patient to immunological tests before to predict the poor ovarian response. There are very many clinicians who give estradiol pre-treatment known as priming in order to improve the efficacy and safety of ovarian stimulation in patients with poor ovarian response. Here also, guidelines say that routine pre-treatment with estrogen in the luteal phase is not recommended, but this is a conditional guideline. If you want to give a treatment with estrogen in the luteal phase, that is after day 20 or day 21, it may give you a better cohort of follicles. It depends upon your experience and expertise. It is a conditional recommendation. But if you want to give OCP pre-treatment to poor responders before starting your ovarian stimulation, it is strongly not recommended because it will bring down the number and the growth of your oocytes. Your gonadotropin requirement will go up and you might not get the sufficient number of oocytes which you require to get that one euploid blastocyst. Similarly, there is something called GnRH anti-delayed start protocol. There is a feeling amongst clinicians that if you start your GnRH antagonist late in the cycle, you might get some extra oocytes or extra, cohort, one or two oocytes might crop up because of the delayed start. But this might be a double-edged sword in poor responders, and it totally depends upon your expertise and whether you're confident that the LH surge will not occur. So this is a conditional recommendation. As far as I am concerned, I feel for the beginning practitioners of ART, it is better to have a fixed protocol for starting antagonists so that you do not make a mistake. One extra day of antagonist will not harm you, but a premature LH surge because of delayed start antagonist might harm the entire cycle. Similarly, what about antioxidant pre-treatment? Does antioxidant pre-treatment improve efficacy and safety of ovarian stimulation? Routine pre-treatment with melatonin is strongly not recommended, nor is pre-treatment with antioxidants, nor is there justification to use alternative medicine-based therapy in poor responders, and that also includes CoQ, which is very hyped, which is being spoken about in many platforms. We do it in ISAR, IFS, everywhere, but the justification, there is no justification as such in using it. Similarly, there is no evidence which justifies lifestyle-related interventions in poor responders. So if it is a woman who is 80 kgs or with a BMI of 29, 30, 31, 32, you are just waiting 6 months for her to lose weight, go to the gym, do a diet, and then come back for IVF. You're probably wasting time. Is GnRH anti-protocol superior to GnRH agonist protocol in patients with poor ovarian response? These two protocols have got equal efficacy, equal results, and are equally recommended in poor responders. It depends upon how comfortable you are with that protocol, and this is a strong recommendation. Similarly, whether you use GnRH and intact protocol or a short GnRH agonist protocol, earlier it was called a flare protocol, and I admit I have no experience in using the flare protocol. There were ART practitioners way back in 2005, 6, 7, 8, 9, 10 who used a lot of flare protocols. So it is conditional recommendation. It totally depends upon whether you are comfortable with a flare or not. Is mild ovarian stimulation superior to conventional protocols in which the whole, load the full dose of gonadotropins is used? Again, mild stimulation with low dose gonadotropins, or whether you use the conventional stimulation with 300 IU of gonadotropin, is equally strongly recommended in poor responders. You're not going to have one result better than the other. In fact, mild stimulation with oral letrozole in combination with low-dose gonadotropins, wherein you will save a lot of money for the patient, and you use conventional stimulation protocol of 300 IU daily for 12 days, both of them will give you the same results. So this is something which evidence is saying now, and this is what the young practitioner is going to adopt in the coming decade. Is GnRH agonist flare protocol superior to the long agonist protocol in patients with poor ovarian response? There is a strong recommendation that the use of GnRH agonist flare protocols is not recommended over long protocols. So if you think you are doing a better job by using the flare protocol, the evidence says otherwise. Similarly, duostim. When you use duostim, is it superior to antag or mild stimulation or two conventional protocols in a patient with poor response? It is not recommended. Here I would like to add duostim means two stimulations in the same cycle. That is the follicular phase stimulation and the luteal phase stimulation. This is also used sometimes in cancer patients. But whether you use duostim preferentially is simply not evidence-based. Similarly, duostim protocol is not recommended over sequential mild stimulation protocols in poor ovarian response. What do you mean by sequential mild stimulation protocol? It means you keep stimulating the patient mildly using CC plus gonadotropin or letrozole plus gonadotropin. In subsequent cycles or only gonadotropin, and start pulling the oocytes or the embryos. Is luteal phase stimulation superior to follicular phase stimulation in patients who are poor responders? It is not recommended. In fact, the response is almost the same. You do not need to, convince your patient to undergo a luteal phase stimulation. Similarly, there's a lot of hype about PPOS, progesterone primed ovarian stimulation. Is this protocol superior to ANTAC protocol in poor responders? Again, it is strongly not recommended, and you are not going to get an extra edge using the PPOS, but you definitely save money over here. And you can, just freeze those oocytes or freeze those embryos. What is the safety and efficacy of recombinant FSH versus urinary gonadotropins in patients who are poor responders? Whether you use HMG or whether you use the costly recombinant FSH, again, both of them are going to have the similar clinical pregnancy rate. The addition of HMG mid-cycle in patients who are hyper-responsive to recombinant FSH. There's one odd patient in whom you have started REC FSH. On day 5, 6, 7 of stimulation, you suddenly find the oocytes are the same size. You're not getting follicular development despite using the same dose. Here it is a good idea to start HMG, and this leads to that extra amount of LH gives you that follicular growth. Similarly, whether you use urinary FSH over recombinant FSH, the urinary FSH over rec FSH in poor responders is not recommended, just to save money, because again, it's a conditional recommendation. But if you have started with rec FSH, you continue with rec FSH. What is the safety and efficacy of recombinant LH plus recombinant FSH versus recombinant FSH monotherapy? Now, there is one patient in whom you call your stock of rec LH, rec FSH, and another patient in whom you do not use rec LH at all. Recombinant LH addition versus vis-a-vis recombinant FSH monotherapy is recommended in poor responders. It is your choice. It is a conditional recommendation. It is not a strong recommendation, but early or mid-cycle initiation of recombinant human LH is recommended in poor responders, provided you are comfortable to use it, provided you are getting results with it, you can continue with that practice. Now, what is the safety and efficacy? Corticotropin alpha is long-acting recombinant FSH, but since it is not available in India, we'll not talk about it. But whether you use a long-acting shot of corticotropin alpha or you use a daily dose of recombinant FSH, they are equally recommended in poor responders, which is a strong recommendation from the guidelines. Now, growth hormone is a lot of height molecule. Is the addition of growth hormone as an add-on or adjuvant superior to no adjuvant in poor responders? It is strongly not recommended. So kindly do not use growth hormone. An extra budget of the extra expenditure of the patient is increased because of the use of these add-ons. Similarly, the addition of testosterone as an adjuvant in the form of a gel as an adjuvant is not recommended, but this is a conditional recommendation. Some centers are using it with good results. But there is one molecule which is available very freely. And in fact, I confess I presented a study of 500 patients using DHEA with good results in ESHRE about 10 years back. So, but now the guidelines say that there's a strong recommendation that DHEA as an adjuvant for 3 months prior to starting ovarian stimulation is not recommended in poor responders. So this has become strongly not recommended. Again, CoQ10, we hear a lot about coenzyme Q as an adjuvant or add-on in poor responders. Again, guidelines say that it is not recommended. Do not waste the monies of the patient. Addition of glucocorticoids as adjuvant, no justification, no evidence to use it as an adjuvant. Does the addition of hormonal assessment, now sometimes you try, especially if you are new in infertility practice, you will try to measure your E2, your progesterone, your LH, along with ultrasound monitoring in order to be doubly sure. But believe me, there is no evidence which justifies the addition of routine hormonal assessment and adds to the budget of the patient, provided your ultrasound monitoring is good, stringent, and you're doing it yourself. Similarly, there is an odd condition in every poor responder. Sometimes clinicians come across an IVF ICSI cycle. They are stimulating the patient, suppose with 225 IU HMG or 300 HMG or FSH, and they get only 1 or 2 follicles. In such patients, is the routine conversion to IUI cycle recommended or not? I do it. I do this conversion, provided the patient has got at least one patent tube, provided there are only 1 or 2 follicles forming and the sperm parameters are okay. So this is a good practice point. Why cancel the cycle? If the patient has got a patent tube and she is ready for an IUI, you can convert that cycle into IUI cycle. Similarly, we are confused about trigger. What is the preferred drug for triggering the final oocyte maturation? As far as efficacy and safety is concerned, there is something called a dual trigger. Dual trigger is wherein you combine an agonist trigger with HCG trigger. The agonist trigger will give you the extra LH and FSH, and HCG will give you the further luteal phase support. But they are equally recommended as far as poor responders are concerned. And I must confess, this is a conditional recommendation. I have used dual trigger. I have done a fresh embryo transfer and I've got pregnancy. Is elective freeze-all embryo transfer beneficial for efficacy in poor responders? Routine elective freeze-all. Everywhere we are listening, freeze-all, freeze-all, freeze-all. But as an IVF center, I'm just nearly reaching my 30th year of practice, and we do not practice routine elective freeze-all of embryos. We still prefer a good, fresh embryo transfer wherever I feel it's, indicated. Similarly, there are very many centers and so many, vendors who are selling you the flushing needle. You buy an OPO needle, it's got that flushing channel. But routine use of follicular flushing technique during oocyte retrieval is not recommended in poor responders. It is not going to bring you that extra oocyte. It's not going to increase your pregnancy rates. Routine ICSI over IVF is not recommended. Routine PGTA to improve efficacy, to improve results, and add to the pocket, the budget of the patient is not recommended. Routine IVM not recommended. Intra-ovarian PRP not recommended. Intra-ovarian stem cell therapy not recommended. IVM in vitro activation of ovarian tissue, another very, very new concept, not recommended in poor responders. And what should be the dose of gonadotropins in this patient? Can you use RFSH? Can you use HMG? There is no data which says that one is superior to the other. If you're comfortable with, highly purified HMG, it's going to give at the end of the day the same results at RFSH. An adjustment, increase or decrease of gonadotropin dosage during the mid-stimulation phase during ovarian stimulation is probably not recommended. Similarly, do not modify the dose suddenly, because every modification or dose adjustment in IVF requires at least 3 days for the dose to reach the plasma level. And how much dose is recommended? Should you go to 300, 375, 450, 600? What is the upper limit? So I attended a very nice conference, Ashray, where they told that probably a gonadotropin dose of as less as 150 IU per day is enough for poor responders. And definitely a gonadotropin dose, because in India we'll never do it, a gonadotropin dose higher than 225 IU or 300 IU is not recommended. Because these patients, whether you're using a 375 IU or 450 IU, or even for that matter, 600 IU, these patients have got their bank balances less. There are fewer recruitable follicles. So the drugs will only make the follicles which are there in the cohort to grow. They cannot generate follicles de novo. So do not add to the budget of the patient. Similarly, there is a cohort of patients who do not form follicles despite using high doses of FSH or HMG, or sometimes, this usually happens with FSH alone. So these are the patients where should you test them for single nucleotide polymorphism? Again, it's a debate. And these patients may have a SNP in the receptor or genes of gonadotropins. And these are usually the patients where the position 680 of the FSH receptor, or these patients are homozygous for serine, and these are the ones who require more gonadotropins than the other patients. But again, the testing is routinely in every patient is not recommended. Now, in such a patients, in order to rescue the cycle, you can use a ratio of recombinant LH and recombinant FSH. FSH to LH ratio of 2:1 can be started at the mid follicular phase in order if you've had, a poor response in the previous cycle. The mechanism why REC LH is successful in such patients is not fully understood, but it is basically something to do with the patients who are, genetic carriers of LH beta. They present resistance to other exogenous gonadotropins, but they may respond well to recombinant LH. So, benefit of recombinant LH supplementation is usually more pronounced in those patients who are the Poseidon group 1 and 2, the unexpected poor ovarian responders, and women less than 40 years of age. But if you try using them in above 35, above 40, you might not get a lot of benefit. So should you increase the dose of gonadotropin in the next cycle? You've got a poor ovarian response. So an increase in gonadotropin dose, especially in unexpected poor responders, Poseidon 1 and 2 can help you because you have seen the poor ovarian response. You know their AMH and AFC is okay, but still a higher dose in the next cycle might help you with the response. So this is how you take your treatment forward in group 1 and group 2. And very less difference is there between the two groups, but you can definitely increase the dose, and you can see that the total number of oocytes required to obtain one euploid embryo is considerably less in group 1 and more in group 2. This slide again tells you that recombinant human LH co-treatment in ovarian stimulation for ART in women with advanced reproductive age has got a benefit, and you get a higher number of mature oocytes, a higher pregnancy rate as compared to those cycles who use HMG alone. So here REC-LH addition does make a difference. Recombinant FSH plus recombinant LH versus HMG does have a difference in the clinical results. So coming to the end of my talk, the management of poor responders depends upon identification of the patients at risk. Stratify them according to Poseidon. Don't use a blanket cover like Ballona. Individualize the controlled ovarian stimulation, because every two individuals of the same age with same AMH might behave differently. Use the best lab practices and tailor the embryo transfer according to requirement of that patient. Because as we soar towards the highest goal of knowledge achievement, the problems become simpler to solve and solutions are always within reach. So that's a wrap, and thank you for participating. And I would like to extend my humble request for contesting as chairperson perinatology committee in Foxy elections this year between 15 to 25th of August. And thank you very much. You can start the next session, I think.
Okay, yeah.
I request our chairpersons to finally, Neelam ma'am.
I think Neelam ma'am is there. Yes,
Neelam ma'am,
ma'am.
please
You're
unmute, ma'am, unmute.
Ma'am, you're
Okay.
muted. Neelam ma'am.
Yes. A very good session, and Monica has elaborated everything so clearly and so nicely, that is unparalleled. And I am very much thankful again on whole of the team for giving me the chance for chairing the session.
Thank you, Neelam ma'am. Thank you. Because when I was presenting this talk, a little modification of this talk in Amritsar last month, Dr. Naren Malhotra told me that, Monica, you have raised so many controversies today. I said, sir, I'm just reading guidelines. Maybe after 10 years, these become the norm. These become the norm, but definitely they are guidelines. And I would definitely like Dr. Padmaja, who will be taking the panel next. She'll be commenting a lot on these guidelines. I know, because she's smiling.
One thing, Monica, there is so much disturbance, very much disturbance in the connecting the, in whole of the session, there is the poor connection between the talk. Anyway.
Oh. So, ma'am, you could not listen to me?
Okay,
Neetu?
no, ma'am. That okay. In beginning, there is a difficulty in the.
I'm so sorry, madam. I'm so sorry. Though my
No,
neck
no,
is
no.
showing.
That is it may be happen sometime. That is the.
Okay. I'm so sorry. So I think we can proceed, Dr. Neetu.
Yes.
Yes, ma'am.
Moving forward, shall I take up the panel discussion? Moving forward for our panel discussion on practical approach to ovulation induction by our dynamic panel moderator, Dr. Padmaja Madam. And we have an panel expert, Dr. Papa Dasari Madam. Dr. Padmaja
Nandini, you
Madam.
can just leave this, Nandini. We will move ahead because we'll be
Please.
reading all these. No problem.
Only few
I think
lines,
our
madam,
work
please.
should speak for itself. Thank you. I hope all my panelists have joined. Dr. Kavita and Dr. Mansi were stuck up in some emergency. I think rest of them, we have a show of hands.
Yes, ma'am. Yes, ma'am. Everyone is there.
Yes.
Monica, one thing I request you. I have some urgent work, so I leaving the.
Thank you for being there with us, Dr. Neelam.
And thank you for being there,
Thank you.
ma'am. Thank you so much. Thank you so much.
Okay.
Padmaja ma'am, with your permission, can we introduce our expert, ma'am, Papa Desari ma'am?
Papa
Yes,
Yes, ma'am. Now, Vishal, please share the slides for Papa Desari ma'am.
Okay. So it gives us proud pleasure to introduce our Papa Dasari Madam. Madam is Dean Research and PG Academics at SVM CHRC, Ariyur, Puducherry. She's also a senior professor at JIPMER Medical College. She has more than 3 decades experience of UG and PG teaching. She is the founder of IFS chapter Puducherry. She has received various prestigious awards such as C.S. John Award, Odilon Award at New Zealand, various awards for her best paper, R.D. Best Award, and the Dr. K.G. Nair Award. She has various national and international publications, and she's a reviewer of various other journals also. Madam has a special skills in obstetrics for USG, gynecological endoscopy, infertility, and IVF. She has established IVF services at JIPMER, and she has delivered the first and second IVF series of JIPMER. It's an honor to have you. Please enlighten us. Now I request my co-coordinator to kindly introduce our panelists. Our first panelist is Dr. Akriti Gupta, Madam. Madam is Joint Secretary of Dehradun Obs Gynae Society. She is a lifetime member of various scientific bodies such as FOXY, ISAR, IFS, IAGU, PCOS Society. She is presently working at...
Dr. Nandini, just speak 2 lines. Just
Yes, ma'am.
speak
Yes,
2
ma'am.
lines of every panelist, huh? Yeah.
Yes, madam. Yes, madam. She is, our next panelist is Dr. Aneet Kumar, sir. Dr. Aneet Kumar, sir, is Executive Committee member of IFS Tamil Nadu chapter. He's a youth icon in fertility at ISAR 2023, Bhopal. Our next panelist is Dr. Ishra Zubair, madam. Madam is a member of Bhopal Obs Gynae Society. She is Associate Professor at Chirayu Medical College, Bhopal, and Director and IVF Specialist Clinic Hospital. I request my co-coordinator to kindly introduce our next.
Thank you, Nandini. I just joined late. Happy Doctor's Day to all. And let me introduce other panelists here. Next panelist is Dr. Kalyani Shri Mali, madam. She is a senior consultant reproductive medicine at Nova IVF Indore. We welcome you, ma'am, for this exciting panel discussion. Our next panelist is not able to join. She will not joining us, Dr. Kavita. Dr. Kavita is not here with us, and Dr. Mansi, madam is not also joining this panel discussion. Our next panelist is Dr. Shweta Agarwal. She is founder member of CGSR, and she is currently working as Director Ashoka IVF Care Bhopal. We welcome you, Dr. Shweta Agarwal, for this panel discussion. Our next panelist is Dr. Swati Rathod. She is currently Professor and Head Obstetrics Gynae Unit at CMC Vellore. We welcome you, ma'am, with your vast experience as panelist in this panel discussion. Our next panelist is Dr. Venkata Sujata Velanki, madam. She is former professor at Dr. Pinamanai Siddhartha Institute of Medical Sciences and Research Foundation, and currently clinical head and fertility specialist at Oasis Fertility, Vijayawada, and secretary of Vijayawada OBGYN Society. We welcome you, ma'am, for this panel discussion. Our next panelist is Dr. Chinta Parimala. She is currently assistant professor, Department of Reproductive Medicine and Surgery, CMC Vellore. We welcome you, Dr. Chinta Parimala. We will all be benefited by your presence in this panel discussion. Our next panelist is Dr. Manjula Rao. She is currently Secretary of Hyderabad OBGYN Society and Senior Consultant and Head of the Department OBGY, Durgabai Deshmukh Hospital, Hyderabad. We welcome you as panelist in this panel discussion, ma'am. Our next panelist is Dr. Niharika Alu. She is past Secretary of Obs and Gynae Society, Vishakhapatnam, and Consultant Obstetrician and Gynecologist, Bright Right by Rainbow Hospital, Vishakhapatnam. We welcome you, Dr. Niharika, for this panel discussion. Our last but not the least, our last panelist is Dr. Uma Shankar SN. He is currently clinical and head infertility specialist, Ahilya Nursing Home and Ahilya Hospital, Guntur, and also Sri Ahilya Hospital, Vijayawada, Andhra Pradesh. He is also secretary of Guntur OBGYN Society. We welcome you, sir, for this panel discussion. Now I hand over the session to Padmaja ma'am, waiting to start the exciting panel discussion on ovulation induction. Over to you, ma'am.
I must thank the entire Symbiosis team for this seamless program that they've been conducting, and I hope we live up to your expectations. And I thank Dr. Surekha Taide and Dr. Kalpana for giving us this opportunity. Today, we will go through practical approach to ovulation induction, and Dr. Papadas Rigaru will give us her expert comments, and quite a large amount of it has been covered by Dr. Monica Singh, but we will see how we go about it. I feel anytime before we start any work, we should ask ourselves three questions. Why am I doing it? What are the results that will be there? Will I be successful? And only when we really have a plan of action in mind that we should go ahead. So for to kickstart the whole program, I wanted to ask Dr. Kalyani Shrimali, what do you mean by ovulation induction, ovarian stimulation, controlled ovarian stimulation, controlled ovarian hyperstimulation? So, does everything mean the same? Is it just like with like bell-bottom pants? Pants are growing longer, shorter. You're having the same pants, but you're just changing the whole way you look at it. Could you just clarify what you mean by these? Dr. Shrimali, are you there? Okay. If not, even Dr. Akriti can take over the question.
Hello, ma'am. Thank you for
Yeah.
the question. And first of all, a big congratulations for such a wonderful webinar that's ongoing. And ma'am, this question, when you posted in the group, I thought even I have not wondered whether the last two are same or not same. So thank you for keeping us thinking on what it is. So I think, ma'am, yes, ovarian stimulation is one larger term. If you take into just the stimulation of ovaries, when you talk about that you are stimulating the ovaries for forming the egg, or for forming one or two eggs or even multiple eggs, that would be just ovarian stimulation as a general term. But then ovulation induction, primarily when we talk about, we are talking about people who have women who have anovulatory cycles. For inducing ovulation in them, that would be termed as ovulation induction. And controlled ovarian stimulation and controlled ovarian hyperstimulation, I still feel they are used very synonymously in IVF. Controlled ovarian stimulation or controlled hyperstimulation, that is the controlled manner where we are looking at stimulating the ovaries and getting multiple follicles in an IVF cycle. So I think controlled ovarian stimulation and hyperstimulation are very much used synonymously. And I think you are there to correct us more.
Yeah. Being in this field, I'm sure even Dr. Monica will agree, and anyone who's been around will realize that there's nothing like controlled ovarian hyperstimulation. You either hyperstimulate, so basically who controls whom? So it will be end of it. When we burn our hands, you realize that you don't have too much control about any of these stimulation protocols. So what is necessary is patient safety first. And that's why I said we should think about what we are trying to do in an anovulatory person, where our aim is to get one mature follicle. Because she's not ovulating, there is no way she can have a baby. So if she ovulates, if everything else is fine, she will become pregnant. So what we are doing is induction of ovulation. So when we are trying to get more number of follicles, because we know she's ovulating, her tubes are patent, there is no male factor, and she's still not become pregnant. So we think maybe there is something difference in the subtle quality, maybe more number can do the job. So when we are trying to get more than one, we call it ovarian stimulation. And where we are trying to get multiple follicles, like in an IVF program, where we know that giving drugs, giving her anesthesia, doing a pickup for just a few follicles every time will not lead to an increased to increase the pregnancy rate. So we call it a controlled ovarian stimulation. So, but essentially what we need to differentiate two is either you're stimulating an ovary that is already working, or you're inducing ovulation in a person who is anovulatory. So basically, how do you decide who needs what? I mean, someone needs, you're thinking she's anovulatory, but in that anovulatory group of the armamentarium of drugs that you have, what are the criteria that you have to decide, I will use this drug for them, I will use this drug. So what are your, how do you look at it? Anit, you can take this question.
Yes, madam. I'm online. I'm online.
Yes,
Yes,
please.
madam. So to decide upon which patient, how do we decide for stimulation? We basically see like what is the antral follicle for the count, what is her AMH, and look at the previous stimulation. So if we taking up a patient for IVF, we see how she has responded to previous follicular study or IUA cycles. If she hyper responded or if she needed like more dosage to even reproduce a few follicles, and then look at the basal E to FSH levels also might give us some idea. So Monica ma'am was telling about even 150 dose for poor over response in the previous talk, but I do wonder that our patients will definitely require a little bit higher dose. Probably 225, 300 is what we normally use in our setup. So that is how we go about stimulation.
Yeah. So basically, first thing we need to do is in a woman, we need to see what type of ovulatory dysfunction she's having. So is it a type 1 where there is hypo, where you would need FSH and LH? Or is it hypergonadotrophic where they need an egg donation because they don't have eggs? Or is it a type 4 where the prolactin is high, where you just need to suppress that and get them to ovulate? Or majority of the patients are 75 to 80% are eugonadotrophic eugonad. So in these patients, this is the chunk of people who are having anovulation that we are going to go ahead. And Niharika, before we go in for an ovulation induction program, do you think you need to do any investigations, or the lady says she has irregular periods? You know, obviously she's having period once in 60 days or 75 days, then she's not ovulating. I will just put on ovulation induction. Do you want to do any investigations?
Yes, ma'am. Thank you, Dr. Surekha, Madam, Dr. Kalpana, and Dr. Monica, and Dr. Padmaja, firstly, for the invitation. And I have to give a disclaimer. I am not an infertility specialist. I'm just a general gynecologist who practices infertility, and I generally push off to my infertility specialist.
Yeah, Niharika, what happens is most of them will come to a person like you primarily before they jump to a fertility expert. So we wanted your inputs on this.
Yes, ma'am. Yes, ma'am. So I think this is the correct question for me. So what I generally do is first I evaluate the male partner. So a lot of times what happens is the female partner gets all the focus and we forget the male partner. So I definitely get a semen analysis done and I rule out if any male factor is there. And when it comes to the female factor, of course, the lifestyle, the weight, all of that has to be taken. I generally did not do AMH before on a regular basis. I would generally do a follicular study instead and an AFC count on day 2, day 3, and then take it up. And if they do not conceive in, say, 1 or 2 cycles, then I would do an AMH. But lately, I'm seeing a lot of low AMH, even in very, very younger women. So I am actually thinking I should start doing that on a regular basis. So, and similarly, SIS or tubal patency, I generally do not do at the first visit because patients generally don't take it so well when you start doing a tubal evaluation at the first visit. So especially when you have a history of PCO, we know it's an anovulation, and on follicular study, you are not picking up or your AFC count is very high, you know it's probably going to help with an ovulation induction. So I generally give, and then if they're not conceiving in a couple of 1 or 2 cycles, then I go and do an SIS. I may be wrong. I would be very happy to be corrected, frankly.
So basically, we need to look at the male and female health. We need to, as you said, evaluate the male factor. And since in Indian population,
Thyroid, yes, I do a thyroid, hemoglobin, sugar, those on a regular basis. Prolactin, there is a history. Yes.
And ultrasound, as Dr. Monica was also emphasizing, we need to make sure that whatever investigation we do, how much benefit we are going to gather from that, and how much is it going to change our way of practice. Suppose you do an FSH-LH ratio, you're seeing a PCO, whatever the FSH-LH ratio, you're still going to go ahead with your
I don't
ovulation
do
lecture.
an
So there is no.
FSH-LH at all, ma'am. I don't do it on a regular basis.
So
I
I'm a
prefer air.
strong anti-panel person. So they have one male infertility panel, female infertility panel, and entire package. I think we should individualize, because what are you going to do with unnecessary investigations?
And that is also why I don't go for SIS and all of that at the first visit. I wait. Lot of people conceive. They don't even need all of that. Yes.
Yeah. And Sujata, in the class 1 ovulatory dysfunction, how frequent do you see it in your practice, and what do you think you need for that?
For class 1 ovulatory dysfunction, that is hypo, we are looking at, it is quite common. We can take it up around 20 to 30%, we can look them in the practice. And it is one thing which is most of the times missed in the initial part of evaluation when we don't do the hormonal profile on the day 2. So patient coming to us in the initial visits, we are only looking at doing an ultrasound, thyroid, prolactin levels, and the AFCs are good, and it's kind of, we tend to move forward with ovulation induction and they might not respond. So here we have to look at identifying these in terms of less number of follicles on the ultrasound scan. Rather than jumping to doing an AMH levels, here we should be ordering day 2 FSH, LH and E levels. And these subset of women respond well only with gonadotropins, that is a human menopausal gonadotropin. So even if we are looking at ovulation induction with IUI, or even not going for extensive ART treatments, they do respond with a human menopausal gonadotropin.
So I think one of the hints you have is they have very infrequent scanty periods or amenorrhea, only withdrawal to estrogen, progesterone. And when you see the ovaries, they are bonsai versions of PCO. That means they have small follicles, all of them are quiet, but the difference is that the ovarian volume is very less. So anything that is out of the classical picture, I think, as Sujata rightly said, quite a large number of times the radiologist, when they do a scan, they will give PCO. Where if we do not look at the ovarian volume, we don't realize, and there have been instances because in these also people have done drilling, and that is the worst possible thing that can be done. So the next most common thing that we have is PCOS among the oral ovulagents. What is the first thing that you will use? Dr. Manjula, are you there?
Right. Yeah, I'm there very much. And thank you so much, Dr. Padmaja, for inviting me over this. And yes, I am also a general gynecologist, not a fertility specialist like you all. And I'm learning quite a lot in this webinar. So thank you so much. And thank you for this question, because this is what the bulk of the cases is in fact in this group. So class 2 PCOS, I mean, PCOS is something which we need to again think of, do the thyroid, do the glucose tolerance test if she's obese, and look at other health issues. Apart from that, if she's a young woman, definitely I would also ask her to lose weight. If she is an older woman and she doesn't have time, and maybe we shouldn't be, I mean, we should do things simultaneously. Then if a glucose tolerance test is abnormal, definitely I think she will benefit with the metformin. And the oral ovulagents, I think nowadays we are all using letrozole as first line, which is an aromatase inhibitor. And I think that dose of 5 mg starting from day 2 for 5 days. And that, I know somehow my experience with clomiphene is just depleting, because for the past few years, we are just using letrozole and nothing else. So yeah, that's it about PCOS. And regarding obese PCOS and lean PCOS, I think they are two, lean PCOS are more difficult to tackle than the obese PCOS. And the role of laparoscopic drilling, I don't do that very often these days. unless it's in the lean PCO category where the LH is very high. Yeah, that's it. That's what I have to say as far as management of PCOS fertility is concerned.
Dr. Swati Rathod, do you have any experience with clomiphene, or have you also shifted all to letrozole and don't use clomiphene anymore? Dr. Swati, you're around? Like otherwise, Dr. Sweta can also take this. Chalo. Dr. Ishrat? Okay, if none of them is around, then we will answer it. So, yeah.
Hello, ma'am. Yeah, myself, Dr. Ishrat.
Ishrat, in a drug-naive person, if you have decided to, do you use at all clomiphene or not at all?
No, now, like since last 2 years, I am not using clomiphene at all. Previously, I had used and see good response, especially in cases where, like, not in PCOS, like where the AMH is between around 5 to 6. But if the AMH is more, like, and the patient is thin, I never use clomiphene. But in previously, I was using, but since 2 years, I was totally stopped. And even in the normal gonadotropic also, and PCOS, no point of using this clomiphene.
I still think CC has a place because it is a comparatively cheaper drug, and as if it is a lean person, a CC50 will almost half the people are going to ovulate. Making it 100 will lead to a 72% ovulation. So, and the pregnancy rate is 30 to 40%. And you need to give at least 6 people CC to be able to get one pregnancy. And the thing is, most of the pregnancies occur only within the first 3 months. So there are very few pregnancies after 6 cycles. So if ever people are using CC out there, you can use it, but only for 6 months. And what are the reasons we gave up using CC, Dr. Ishrat? You said you had almost given up.
The endometrium thickness was a problem initially. That endometrium used to be very thin at the end of even the follicle is growing, but we found the endometrium is not growing properly, and sometimes there is a risk of hyperstimulation is also there. I've seen 5 follicles in ovaries, so sometimes I have to cancel the cycle, so I stop using it.
So basically, vasomotor symptoms, hot flushes can be there. It is not totally benign. There can be abdominal pain, nausea, vomiting, breast tenderness, headache, hair loss, and visual disturbances can sometimes cause. They can lead to a long-term irreversible damage. And as she said, the risks with multiple pregnancies, OHSs, and a higher rate of miscarriage. And you call it just for completion's sake, any one of you can take this question. What is the difference between resistance and failure?
Ma'am, if we're not getting any ovulation with a clomiphene in 6 cycles, that will be a resistance, but they are ovulating, but failure to get pregnant. Pregnancy is not happening, then it will be a failure.
So resistance is 150 milligram, 3 consecutive
3
cycles.
cycles. Yeah, it's not 6, it's 3.
Okay, in 3. And there are modifications, and the reasons for this resistance are most often obesity. Sometimes these people have a little amount of hyperandrogenism increased. They're not classical congenital adrenal hyperplasia, but adrenal also contributes to some of the androgens. So addition of dexamethasone, addition of insulin sensitizing might help in that. And as I was telling you, the highest fecundicity, that means if CC were to lead to ovulation without any side effects, the maximum possible pregnancy rate is around 15%, and it will work within 3 cycles. So if it fails, then it could be because, as Dr. Ishrat was telling, there is an anti-estrogenic effect on the endometrium, anti-estrogenic effect on the cervical mucus, abnormal uterine blood flow, impaired placental protein synthesis, maybe subclinical pregnancy loss, maybe this anti-estrogenic effect also has an effect on the tubal transport and the oocytes. Has any one of you ever used tamoxifen?
I have not.
No.
Yes, ma'am, I've used tamoxifen, but
Yes.
not exactly in ovulation induction, but yeah, in natural cycle embryo transfers.
Yes. So tamoxifen was discovered as early as CC. It is basically a prodrug, and the difference is that estradiol will fit into the receptor because of the shape of tamoxifen. You can see a projection out. So it does not let the estrogen receptor close and have a translation. So and because it is sitting there, it will not let estrogen also come. So translation and transcription of the protein of estrogen receptor does not happen, and using tamoxifen instead of using, in some people, when you're trying to do an FET cycle, you see that giving just estrogen does not lead to an increase in thickness of endometrium beyond 6. So in those people, using tamoxifen has benefit because it expresses the progesterone receptors, and it increases the sex hormone binding globulin. And if you're planning to use it for ovulation induction, it is an off-label use. 20 to 40 milligram per day can be there. Pregnancy rates are similar to CC. And as we said, aromatase inhibitors are the most common medications that are used. And why are the risk of OHSS, we say, is much less than with CC. And can anyone take us through this picture, which is showing us why multiple follicles are not stimulated with this? Sujata?
Yeah, actually it suppresses the estrogenic production. So thereby it encourages the production of FSH and LH hormones. So it acts as a level of these are all a set of hormones which are acting as aromatase inhibitors. So that's the reason why development of multiple follicles is hindered. So that's the reason why we see most of the times monofollicular development when we give these aromatase inhibitors. And though they say that they are in the off-label now for PCOS, and the PCOS guidelines now are saying that we can use letrozole as a first line of drug instead of CC.
Yeah, so basically, because it is not blocking the receptors at the level of the hypothalamus and pituitary, the rising estradiol level with the growing follicle makes the GnRH levels down, and so the FSH window closes. So that is the beauty about letrozole. And it is highly potent, selective, with a short half-life. And because it is 99 point, within 2 days, 90% clearance through the kidneys. So by the time ovulation occurs and by the time fertilization occurs, letrozole is not going to be in the body, unlike cumulative doses of CC that can occur, the zooclomifene persists in the body for a very long time. And it is not totally benign. So suppose we increase the dose, we can still get multiple follicles. So 5 milligrams is the maximum dose that is recommended. Even 7.5 is not really advocated. And going on to gonadotrophins.
Ma'am, I generally see sometimes a lot of cysts with letrozole. So what could be sometimes?
Because folliculogenesis is an ongoing process in the multiple waves that are occurring. So in PCOS, what happens is that the FSH was suppressed to such an extent that the follicles which could grow did not grow. Here, when you give letrozole, the E2 comes down, the FSH increases, and all these follicles that are ready to grow will start growing. But all of them are not in the same phase. So some will grow off to 16, some will be at around 12 to 14. So these will continue to reside and be there as functional cysts at the next cycle.
Yeah.
Got it? Okay. Anit, do you have any preference of gonadotrophins with the so many things that are evolving? What do you think? The new is the best? You stick to something you know?
Uh, Madam, so for IUI cycles and for like follicular study cycles, I prefer to stick with HMG, madam. So only like very rarely I move on to recombinant FSH. But if it's IVF, I use a combination of both recombinant FSH and HMG. Because a lot of studies, talks going on, importance of LH in ovarian initial phase of ovarian stimulation. So I use both recombinant and HMG for an IVF stimulation. If it is IUI or follicular study, I stick on to HMG, what 75 or 150 to get 1 or 2 follicles.
Akriti, how do you do it?
I think, ma'am, even for IUIs, and I prefer using HMG, and also depends upon what kind of patient this is. Sometimes you have PCO, still you have to use a recombinant preparation, even for a single time. For if you're using FSH, if you're using PCO, and you are planning to do an IUI, so it would not depend whether I'm doing it as an IUI. It would more depend what kind of patient it is. So if it is a PCO patient and ovulatory, I would still prefer to use an FSH combination. And unlikely add an HMG. But then if it is in more of a maybe an unexplained infertility, having ovulatory cycles, and she is then HMG would be preferred in a highly purified combination. Then I would not use a recombinant. So it's, I think, more of a doctor's choice, as well as what kind of patient it is, what is the FSH, what is the LH, whether it is type 1 anovulation or type 2 anovulation, what are we hitting at. It is not primarily whether it's an IUI or an IVF. Any of the two, it has to be which type of anovulation it is.
Yeah. And I also think the financial status of the couple matters, because all of us know that in a single cycle, not all of them are going to conceive. So what we need to do is stretch their finances too, so that they can go through multiple cycles and achieve that pregnancy, which will result in a carry home baby rate. And do you have any particular preference for a particular protocol for one group, like how Dr. Monica was telling us about poor responders, the protocols that we can use like that? Dr. Shrimali, could you tell us about your choice of protocols? She's not there. Usually the dose of gonadotropins depends upon the age, the reserve, what are we doing about the antral follicle count, the AMH, and what we are planning. Are we planning an IUI program or an duration of infertility and cause of infertility? Monitoring of the cycles, Dr. Monica was telling me you don't need to do most of the times avoid hormonal evaluations. So, Shraddha, how do you monitor your cycles? Yeah, anyone?
So if we're going for an IVF cycle, I prefer to do monitoring with ultrasound and with hormones also, madam. I'm still used to monitors to hormones. I, as madam was saying, I do a lot of fresh cycles. I'm not a totally freeze all person. So to monitor my fresh cycles, we want the progesterones to be less than 1.5 or less than 1 is what my cutoff is. There are various studies showing different progesterone cutoffs. So you do ultrasound scan on day 5. To decide whether you want to start antag on the next day. So we all follow, I follow fixed cycle, but still, if the patient is hyper responding, I want to start a little bit one day earlier also, or delay it by one day. So 5th day, do the E2 LH progesterone and then ask them once in 2 or 3 days until the follicles are 17, 18 mm, and then plan a trigger. So this is how I do. On the day of trigger, I again do my E2 LH progesterone to make sure whether just to make sure that I can do a fresh transfer or not.
Okay. And Akriti, your trigger choice?
Ma'am, the trigger choice, if it's an IUI cycle, and if the anyways, first is important that the total number of the follicle which are more than 14 should be less than 3. So if even if we have not a monofollicular growth, then if we are giving a trigger, definitely it has to be either again it can be recombinant HCG, or it can be highly purified. So or it can be even urinary, because there are studies in IUI that have proven that even urinary and recombinant and either the highly purified, they give equal pregnancy success rates and all. So it's again patient's pocket. Here we decide whether she can afford your Ovitrel or she can afford a urinary, and we can proceed with that. In case it's for IVF cycle, then definitely, ma'am, it would depend upon, as sir said, E2 levels if we are seeing, or it is a fresh cycle, or we are doing a freeze-all cycle. What kind of a E2 is there? If we think it's less, and if we think that a dual trigger would be needed, then we would add a decapeptide to it and give Ovitrel along with that. But yes, in IVF cycles, I don't prefer urinary or highly purified combinations. I mostly use a recombinant HCG trigger along with triptorelin or without triptorelin. And sometimes if it's a PCO patient, then alone decapeptide is also used, depending upon, again, the profile of a patient, whether she's having any risk factors of OHSS. So then only prefer even agonistic.
And Sujata, do you give luteal phase support in all your IUI cycles?
If it is a monofollicular development, single follicle where we are doing an IUI, there's no need to give a luteal support. Actually, this is what data suggests and this is what literature says. But taking into consideration the number of years of marriage, the age of the patient, how many cycles they've been through, and if at all luteal phase deficiency could be a probability, we might be missing out an option. So it would be better we continue and give them a smaller dose, a single dose of progesterone as a luteal support, even in an IUI cycle. And I give for my IUI cycles as well.
What are the precautions you will be taking in a PCOS?
When we are looking at a PCOS patient, the first thing is that you have to anticipate a hyperstimulation at the start of stimulation itself. Sometimes even a couple of months prior to starting the stimulation itself, we should be identifying the risk factors. If we could advise them to lose a couple of kilos of weight, give them proper nutrition, and improve their lifestyle and health status, probably we can start them with a lower dose of gonadotropins at the start of stimulation. It is always advisable to do the day 2 hormonal profile in these patients, because if we will have an idea of whether they are a candidate who might have hyperstimulation. So those adjustments have to be very critical, and we have to be very vigilant on the possibilities of ovarian hyperstimulation. And clinics should have a place of ovarian OHSS free clinics where we need to give them precautionary methods in terms of agonist cycle, triggering, avoiding the HCG trigger, and see that the E2 levels don't rise beyond 3000. And if we are having an E2 which is more than 3000, we may have to start them on methods like giving them aromatase inhibitors, cabergoline, antibiotic like doxycycline instead of regular antibiotic after OPU. So these are a few methods and things that we can do to avoid OHSS in the post-operative period. The most important thing here I would like to stress on is the usage of metformin. So when you're having these patients on metformin, the chances and incidences of OHSS will be quite less. Most of the times it happens like patients after they have a oocyte retrieval, they kind of can't tolerate food, can't tolerate taking metformin. They might skip the medication. So we have to be very vigilant in asking them whether they're continuing their metformin medication. It can reduce the OHSS drastically. Hope this helps.
Yes, definitely. So in endometriosis, will your stimulations be any different, Ishrat? Do you believe in longer down regulation before we go in for a stimulation for endometriosis?
It doesn't help, madam, the down regulation for endometriosis. Routine, pre IVF, the estrogen, sensitize the woman for one cycle, and then you can start your stimulation as a routine.
Yeah.
Unless if you're
Because
planning for a fresh transfer, you might consider one dose of agonist, but generally it doesn't help agonist suppression.
the thing is, pharma pushes a lot of GnRH agonists as a magic band for endometriosis, and quite a large number of gynecologists get carried away after doing an ultrasound or a laparoscopy. They put them off on GnRH agonists. So I don't think that should be done. And even in unexplained infertility, basically in this, giving good gonadotrophin, trying to avoid OHSs, and going ahead with an IUI might be a better deal rather than telling them just giving them behavioral therapy, I think. And the low reserve was very extensively covered. And regarding the ovarian stimulation protocol, I believe that this is how we should be looking at it. So, are we expecting a high response? Here, our main aim will be to minimize the OHSS risk. So, an ANTAG protocol with minimum, with the threshold of FSH stimulation, what we need is what we need to do. When we expect a normal response, here our aim is to get at least those magical number of 15 oocytes, so standard treatment. When it is an expected poor response, here we don't want to give more dose. So giving the optimum FSH stimulation, not giving a sub-threshold and an ANTAC protocol still works. And pre-treatment, any of you want to comment about this estrogen and progesterone OCPs?
So
Yes, please.
okay. So for pre-treatment, the guidelines are saying only about OCPs. Do not use OCPs because it might decrease your IVF success rates. But either estrogen alone or progesterone alone can be used as a pre-treatment. There is not much of discussion about using estrogen and progesterone together in the pre-treatment phase. But either using estrogen in the last 7 days or progesterone in the last 7 days, any one of those will do a pre-treatment because it will bring all your follicles to the same size, and it increases the intrafollicular hormones, and you will get a better crop of follicles and better crop of oocytes is what the suggest says. I use the pre-treatment of the estrogen alone in the last 7 days of the cycle before I start my stimulation.
OCPs were previously used 10 years ago when we had very few embryologists and they would give us the time slot. We had to do batches. So I think OCPs did not really give us that bad pregnancy rates. But long use of OCPs is what is definitely bad about it. I mean, you can't put them on 6 weeks, 8 weeks, and then as soon as you stop, expect them to take off. Okay.
Actually,
And
the thing, the problem is that in like Western countries, they give OC pills till one particular day. Immediately the next day, the start of the stimulation.
so
In our
5
setup,
days.
what we do is we stop OCPs and then wait the patient to, like Indian setup generally, we start the patient to bleed, and then we start the stimulation after 5 or 6 days after starting the stimulation. There is enough time for the washout of the OCPs to happen also. So that is the reason why we feel that probably OCPs doesn't have much of an effect. When I was also using OCPs before, but even we make sure the patient bleeds and then only we start the stimulation. So don't know.
So, as Dr. Sureka said, we should critically do a retrospective case series and look at our OCP use and say that this is not always true. And as we said, regarding pre-treatment that goes, and we said Are these protocols agonist, antagonist? Anyone is using an agonist protocol? Have all switched over to antagonist? What are your experiences? Ishrat, you're around? Or Dr. Shrimali? Otherwise, Akruti, please. We'll finish off the discussion among
Okay.
us.
Ma'am, more of it, I use an antagonist protocol. And yes, agonist sometimes, if it is a patient of like endometriosis, as already discussed before. And I'm more comfortable with an antac protocol because we have an in-house embryologist with us. And since that is how I was taught. But yeah, probably if I would have been taught 10 years before, I would have been more comfortable with an agonist protocol. And I think the results are comparable, except there are certain guidelines, as Ashley has already been commented, that normal responders or poor responders, the results with agonist or antag are almost similar in terms of clinical pregnancy and even the number of follicles retained, number of the quality of embryos which you get. Only PCOS and hyperresponders, they suppose that, antag should be preferred. So I think for overall, it's this is the gist.
Yeah, so that's what it says in women with Anita had told, I will look at the previous response. So that is a very good hint that if they say I had large number, I was having bloating, but because quite a large number of people lose their records because they give up after one cycle, and then when they come to us, we have absolutely no record. But that is if they have given us that history, that they say that they were told that the complications will be high, all freeze was done. So in those, maybe we should be using a antag. And oral ovologen to decrease the dose of stimulation. Sujata, do you recommend any time, or you say nothing doing, you just give one pure medication?
When we are having especially poor ovarian reserve, low reserve patients, where we are expecting 1 or 2 follicles, that's where we can think of adding an oral ovulation and a low dose of gonadotrophins like HMG 150 with clomiphene citrate 50 mg. So we do get, if we're not, anyway, we are not going to get more follicles, so that dose should be fine.
So in this group where we are expecting a poor response, so clomiphene with gonadotrophin can decrease the thing. And especially in fertility preservation, once their anti-estrogen like letrozole is definitely considered. And as we were saying, each one of you, what is your, for a normal response, what is the dose that you start with? And when you do your scan, do you change your drug dosage, increasing it, decreasing it? Do you do it? Each one of you can comment on this. We'll start with Akriti. What is your starting dose? And did you change the dose midway?
So I'll start.
Yes, please.
Okay. So, madam, so I usually try to start a higher dose and then come down. So my starting dose is usually on the higher side, 300 or 450, and then see them how they respond on day 5, and then reduce it to 225 or accordingly how they respond. Because initially I feel that recruitment phase they need a higher dose. So since we are aiming for 15 follicles, especially in our Indian patients, South Indian patients, I feel that they require a higher dose, and all these European doses doesn't work at all in our scenario. Be very frank.
So the other panelists can also comment on that. Niharika, do you see prescriptions of low dose, high dose, very high doses? So you must be getting your patients back from IVF specialists.
Well, most of them, I think 225, 150 is the minimum that I have seen. I have not seen any step ups usually. It's mostly step down only that I have seen.
And Manjula, how has your experience been?
Manjula ma'am is left, I think. She's just left.
Okay, fine. Okay. So even in poor responders, the gonadotrophin should not be more than 300 because all the receptors, there are very few follicles and all the receptors get full. So there is no point in doing it. And adjuvants to stimulation, these are each one's flavors. And I feel as long as I think Dr. Sujata has quite a good experience with the growth hormone, Sujata.
Yeah, actually, it's you, when you are saying flavor is growth hormone is my flavor.
Yeah, that's what.
Get good quality oocytes when you add a growth hormone to them. And the thing is, like, you already have a gonadotropin in place, so it's not the only drug. So that's why you can even start with 4 units, 6 units, or 8 units, depending on the response the patients give us at the stimulation. Ideally, when we are starting any stimulation protocol or drugs, I feel like we shouldn't change the medication. Like most of the times, we do a scan on a fourth day, we don't find response. There's no point in increasing the dose. At least waiting for 6 days of the same dose, and then we don't get a response. That's where we can increase the dose or add these adjuvants if required.
I am seeing a lot of prescriptions of sildenafil these days. So a lot of patients complain of a lot of difficulty with the sildenafil also. They're not very happy, but they are taking it because the infertility specialist insists. So what is your take on it?
Yeah, not much of evidence on improvement with sildenafil, and there's a lot of discomfort. I agree, whatever Harika is telling. So the ideal dose is like they have to take 4 times a day, 6 hourly. But certain sildenafil every 6 hours is not very comfortable. But there are few studies which show that it improves the blood circulation to the endometrium in terms of at the time of transfer. So probably temporarily we can give it at the time just before transfer, and then we can stop it. There's no need to continue sildenafil once the pregnancy test is positive.
Okay.
And we already had a talk about the dual and 2 consecutive stimulations. So basically only in the context of clinical research and in urgent onco fertility. And do you anyone use Doppler, power Doppler 3D to monitor your follicles during the stimulation protocols?
Probably for an IUI cycle, we can use the power Doppler to see the vascularity 70% or 50% vascularity. For an IVF simulation, we don't use the Dopplers much.
So basically, it is not very practical when you are having 14, 16 follicles compressing
Yes,
one
yes, ma'am.
another, and endometrium. In our IUI cycles, I tend to measure the endometrium, although the recommendation is just see the endometrium on the day of pickup. But for me, looking at the endometrium helps me have a mental picture of what is the amount of estrogen that is coming from that follicle, how is the endometrium responding to that. And I think that really helps, although the recommendation is you don't need to do an endometrial measurement. Anyone?
Even the cervical mucus, ma'am. Even the cervical mucus.
Yeah, even the
So
cervical
just
mucus.
yeah.
Okay. And trigger, we already decided that we are going to do. And previously we used to give 10,000, and now we all know that around 1,500 IU of HCG is enough to trigger the oocyte maturation and get us M2 oocytes. So not more than 5,000, taking into condition our biological variability and the temperatures that we have. And when risk of OHS is there, as one of the panelists already said, an agonist trigger might be there. So the most important thing in this whole exercise is prevention of OHSs. As Dr. Sujata already said, there is numerous interventions from albumin, starch, aspirin, glucocorticoids, calcium infusions, carbacolin. Numerous studies have been done, and knowing your client, the woman, when they're young, low body mass index with high Dopplers of intra-ovarian in the stroma, PCO, OHSS previously, more than, I feel when the more than 15 follicles you're retrieving at OPU, and when there are more than 18 follicles of 11 on the day of HCG, that is where we should be very alert about OHSs. And we already talked about luteal phase support. There are so many forms of luteal phase support around. And can each one of you tell what is your favorite luteal phase support? Ishrat, you're there? Or I think last Akriti, Ankit, Sujata and me and Niharika are left. So each one of you tell out of these what is your favorite.
I just do the normal ovulation induction. So I generally don't give too much of luteal phase. I refer.
Okay. So you don't in your you don't at all give any luteal phase support, no progesterone.
Post conception, then I continue till 12 weeks,
Okay.
and then I decide to stop.
Okay then. Sujata?
Yeah, if it is a natural or ovulation induction and an IUI cycle, it is micronized vaginal progesterone, single dosage, sustained release 400 milligrams. If for my IVF FET cycles, it is 100 mg of intramuscular progesterone.
Anit, you?
For an IVF cycle, I do use IM progesterone still, madam. So at least till positive comes. So after positive, BRAS positive, I will change on to oral or vaginal progesterone. So somehow I've been trained in that way, so still continuing that IM progesterone thing.
Akriti, you?
I think for progesterone in IVF cycles or even in IUI, for IUI, a simple progesterone, either a vaginal or a dydrogesterone would do. Whether the patient is more comfortable with vaginal, then I'll prefer a vaginal first, then dydrogesterone. And in cases of IVF cycles, since I mostly do frozen embryo transfers, and most of the times dydrogesterone 10 milligram twice a day dosing along with the vaginal suppositories of 400 milligram is the one which I prefer. And in case there's a failure, she has failed before, or if the progesterone levels are not optimal before the day of embryo transfer, then I add a subcutaneous progesterone to her. So it more likely depends as an individualized approach, but as a standard for every patient, it is dydrogesterone and vaginal.
Okay. So, and freeze-all cycles, are you all advocating? I think all patients, we should not be applying the same rule. So it was basically designed to prevent OHSs in a person who will be a high responder. Normal responders, if you think there is a hyper response and you think the too many hormones to lead to a success in a fresh, you can. But in poor responders, if you need to pool embryos, you have. So I think we need to really, really stratify and see and do that. And I hope we have brought some clarity into the entire confusion of things that are there in ovarian stimulation. And depending upon what we expect in the response, if we look at a simple protocol like this, we have this stuck on our wall, I think we will be able to do a good job. Thank you very much, Dr. Monica, for giving us this opportunity to share our thoughts and time with us. And I thank my wonderful panelists for bringing.
Padmaja, I am here. Dr. Padmaja.
Dr. Papa,
I
Papa would like to
She
Yeah,
forgot
please,
about
comment.
me.
No, madam. I thought I'll first finish thanking them before they also leave. Please tell me, Dr. Papa. That's me.
Dr. Papa
Because
Dasri,
I
we are
am feeling useless sitting
to
here.
Oh, sorry, madam.
So,
No, that was not a purpose at all.
no problem. No problem. But I have few comments to
Yes,
make.
madam, please.
It is a wonderful kickstart you have done, differentiating ovulation induction and stimulation and COH. That is very good. Coming to the investigations, I have few things to say. It is always better to have a panel of investigation, not doing all hormones, but in India, because I have seen few of the failures even after IVF coming back, they were not investigated for tuberculosis. They've not done a Monto test. They've not done a complete hemogram. Even a vitamin B12 deficiency can result in ovulation, failure of in an ovulation. There are some studies about it. So a complete hemogram with peripheral smear is very important. Monto test, ESR, along with all other tests. And regarding the hormones, somebody said very young people are coming with low ovarian reserve.
Yes, ma'am.
One of the reasons we have seen is that hypothyroidism. We've done a study. So hypothyroidism is very, very common in infertile people, almost 20 to 30%. It depends on which belt of India you're residing on. The hypothyroidism is significantly associated with low AMH levels and an ovulation. The study is published in Journal of Human Reproduction recently, our study, one of the PG thesis. So all women should be screened for hypothyroidism. Of course, hyperprolactinemia, both are interconnected. And then before inducing the ovulation, you need to normalize these. At least 3 to 6 months therapy has to be given. So when you don't normalize your TSH, when you don't normalize your prolactin, you are not going to achieve any ovulation, even if you give maximum dose of ovulation inducing drugs. So this is what needs to be conveyed, that you don't hurry up. Correct the endocrinopathy first, whether it is IGT or hyperprolactinemia, hypothyroidism. This is a must. Correcting it over 3 to 6 months, you wait, normalize, and then you induce ovulation. Definitely, I have seen in experience, they do ovulate with oral ovulations also, they do conceive. And in failures, if failures come to you, nowadays, you need to investigate a cervical swab or even endometrial culture needs to be done. That is about the investigation, because chronic endometritis, again, they may be ovulating, but there is an implantation failure. So if you have got a failure cases, then you need to rule out this also, chronic endometritis, into your investigation panel. In failures, you have to do. Then comes to your, I think you're talking about CC, non-PCOS. Yes, definitely CC we can try. And I had lots of positive pregnancies when we give CC with antioxidants. That is a combination which is Vova Shield. Of course, nowadays everybody's converted to letrozole, but my practice is PCOS. Yes, as per recommendations, letrozole is the first line of treatment, but non-PCOS, yes, you can give CC with antioxidant combination. And regarding tamoxifen also, we've done a study, 30 milligram dose and 60 milligram dose we have compared. There is no difference in ovulation, but yes, the implantation rate is little higher, where we gave for CC resistance people tamoxifen. The endometrial thickness has definitely improved significantly. There were few higher pregnancies, but it was not statistically significant. So that I just want to share that. And metformin, yes, you have discussed about it. But what about the myo-inositol? How many of you are using the myo-inositol? And metformin combinations are also there. There are few studies when you use myo-inositol and metformin combination. Some of the resistant cases may respond. And regarding the endometriosis, what is your experience with PPOS protocol? You said long protocol. Yes, there is no significant difference with antagonist and agonist protocols. But PPOS for this endometriosis, some people are saying that it is better. Yes, that's what I want to. How many of you do sono AVC to differentiate the cysts from the follicles? Anybody is practicing sono AVC?
Ma'am, I do Sono AVC, but I do it only for teaching purposes. Means when I'm teaching my students, DNB students, I want to introduce that machine, the features of a fancy machine. But practically speaking,
In
I
IVF.
have, ma'am, in IVF, what I have done is I have taken a group of patients in the
Yeah, it is going.
cycles. I
Net
have found a
problem.
difference. No, there's a problem, ma'am. The Sono AVC will over measure the follicles. I have seen. Suppose the follicle is 11 mm. You are having 4 follicles of 11 mm. With Sono AVC, it'll measure it something like 12.5 or 12 or sometimes even 13 that I've seen. So I was a little reluctant then using it and putting it on
Not
paper.
routinely, not routinely, but some
Yeah,
cases
yeah.
like I really enjoyed your talk on this low responders. It's so nice. But
Yes.
in that cases also the follicular architecture is not very good, and then you have doubt whether it is really a follicle or it is a kind of cyst, and the measurements are not so great, like it is not more than 24 millimeters. You can think of cyst maybe. In those cases occasionally you may use it. So it is a very nice session. Thank you for the invitation, Dr. Monica.
Good to have
Okay.
you, and Dr. Padmaja has done a brilliant job. So all the
Very
panelists.
nice, very nice.
I wanted to ask
Nicely
you
she
about
brought out.
ma'am, are you using PPOS routinely?
I have not used. I have not used, but
I've tried, madam, but the thing
mm.
is, you're reluctant to try it on the good prognosis patient because you know that giving a standard protocol will give a good one. So when we try it on the poor prognosis patient, anyway the poor prognosis, so 1 or 2 cases you get your hands get burned. So there is a reluctance initially in going ahead for that.
Yeah.
And my embryologist is not happy with the oocytes I give after that.
Oh,
He says,
he's not.
madam, he says either the at ICSI the wool lemma did not give me any resistance, or he says they're dark. Then you see little fragmentation. So you don't know that. I mean, it's too early to blame it, but you tend to associate with that. In the cycle, you do 3-4 cycles, you don't even get one good response. Then there's a hesitancy in starting. I
So,
don't
Doctor,
have.
what does ESHRE say about PPOS, ESHRE or ASRM? What are their
They're
recommendations?
they're not
Better.
really putting it in the mainstream as yet because the studies are not too many double blind with a good statistical difference. So we still have to see in which place we will be able to put it right now.
Right.
When we are using normal responders, it is okay. Like we get on the cost drastically for the patient.
Endometriosis.
Yes, endometriosis, not much I've tried. I've tried on normal responders. We have a lot of cost cutting because secretariat, the cost of
yes.
the
People are using it in donor cycles also.
yes,
With
donor cycles also we are getting right.
freeze-on. Yeah, because donor cycles are usually normal responders. Usually they are Paris women, and you have a freeze-all strategy. So it might work that way. But personally, I have got very less experience, so I wanted to ask Papa ma'am and Padmaja ma'am.
My
So
experience is less than you. You are doing for 30 years.
so ma'am, you remember I met you at JIPMER? Do you remember?
Yes, I remember. A very sweet talk and sweet everything very sweet about you. I admire you a lot.
Thank you so much, ma'am.
And we are
Thank you
looking
so
forward
Thanks.
to meeting Dr. Papadasari at Vijayawada for the IMS conference we're having.
Maybe I'm coming to go to temples.
Yes, definitely, madam.
Vijayawada.
Okay.
Okay, nice way of your questions. Everything so beautiful, and you did teach them also in between. Okay. Thank you very much. Good night.
Thank you.
Thank you,
Thank you
ma'am.
so much.
Thank you for the opportunity.
Hi,
Thank
Anit.
you
Hi,
so
Anit.
much.
You in Mahabalipuram, Anit.
Yes, madam. Sure, madam. Will be there.
So, Anit is one of my young friends.
Yes, madam.
We get along very well, don't we? So,
Very true, madam.
thank you so much. And Nivedita is another friend I have from Jipmer, and I feel so elated when I see my Jipmer friends.
Thank you. Thank you.
Yeah, and Papa ma'am, of course, Padmaja ma'am, of course, we are all conference buddies. And thank you, Sujata. Thank you. Niharika is always with me. So many times we've met.
Ma'am, I'm also a Jipmerite. I'm Papa Ma'am's student also.
Oh, wow. So you are a Jipmerite and Shaijas Nair is a Jipmerite.
I'm
Yes.
just 1 year junior to him, and Nivedita is 2 years junior to me. So we are all undergrads from Jipmer.
Very nice meeting together.
Yeah.
Yeah. And this is just, I know it's far away, Bhopal is far away, and there are so many conferences, but we have a national conference coming up called the Bhopal VPCon. This is on 12th, 13th, and 14th of July. Anybody, like now it's too late to invite actually, but still, this is something which we are looking at. We have got around 8 workshops. We have got fantastic scientific sessions. So that brings us to the end of this beautiful webinar. Thank you all faculties and thank you so much.
Nice.
I wish you all the best, Monica. Thank you. Thank you, ma'am. Best of luck.
So I don't think we have the audio here, but hearty thanks from all of us till we meet again. And thank you. Thank you. Have a very good night. Bye. Thank you, Intas. Thank you, Neetu, Purva, and
Thank you.
Nandini.
Thank you, ma'am.
Thank you, the tech support. Thank you so much. And
Thank
all
you.
this will be available on YouTube in the form of a link, which you can share with your students and with your colleagues. Thank you so much. Bye. Bye.
Bye.
Bye.